Three, two, one. We are live now, sir.
Good evening, everybody. Myself, Dr. Vishal Dave, Medical Advisor, Intas Pharmaceuticals. On behalf of Intas Pharmaceuticals, I welcome you all for this Synergy led webinar on the topic laparoscopic myomectomy, advancement, challenges, and best practices. Before starting the webinar, we will have a prayer.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
It is my privilege to introduce the convener of the webinar, Dr. Monica Singh. Dr. Monica Singh is President-elect of Bhopal Obstetrics and Gynecological Society. She is Founder President ISOAP Chapter of Bhopal. She is National Executive Member of ISAR. She is Joint Secretary come Joint Treasurer of MPIAG, and she is Coordinator of Foxy Infinity Committee. Now I would like to hand over the session to Dr. Monica Singh.
Good evening to one and all, and thank you, Dr. Vishal, for the kind introduction. I welcome you all to the 11th episode of Synergy. This webinar series we had started in 2024, the last part of 2024. We are on the 11th episode already, and this is in synergy with the Madhya Pradesh chapter of IAGE as well as the Bhopal Obstetrics and Gynec Society. I'm very happy to announce that because of the efforts of my team, we have been granted 4 ICOG points for this webinar. There are lots of ICOG fellows who are attending this webinar, and they can take advantage of the points granted to the webinar. And we all know that we have come in synergy. We are now coming to focused topics. And the topic we have selected today is laparoscopic myomectomy. You can see the doyens of this art and this surgery. Dr. Uddhav is there with us. Dr. Jyoti Mishra will be joining soon. And there is a plethora of panelists and experts who will be giving their viewpoints and giving their, expert tips as we proceed with the webinar. A little bit about, I was just interested when it started lap myomectomy. So laparoscopic myomectomy was started in 1979. The first surgery was done for subserosal fibroids because that time the surgeons were not very confident of taking out deep-seated myomas. Then gradually they started taking out the intramural myomas, and now it is one of the most commonly done surgeries. So, as we proceed, we will be unraveling more and more facts about laparoscopic myomectomy. And I'm so happy that our president, MPIAG, has joined just now. She is also our chief guest, and she is a very, very dear mentor and teacher in the state of Madhya Pradesh. She is Dr. Kavita Bapat, and she has taken over as president of MPIAGE. Can I have Madam's flyer, Vishal? Welcome, ma'am. Madam is president of MPIAGE. She is a very, very renowned figure in the whole state as well as in the city of Indore, which is the commercial hub of MP. It's called the Bombay of MP. She has been vice president of Foxy in 21-22. She has organized several wonderful conferences in the city of Indore, including the recently concluded AICOG 2022. She is a renowned and expert vaginal surgeon and a specialist in one-day hysterectomy, in which she conducts vaginal surgery certificate courses at her center, Bapat Hospital. Madam is a keen academician, a peer reviewer of Jogi, editor of Apollo Medicine, and she initiated the registry of primary ovarian insufficiency. She is called the Naika of Indore because of the award given to her and the Captain of Industry Award. Madam is Madam is also, held post. Madam is presently the president of Indore Menopause Society, as well as the president of MP chapter of Vaginal Surgeons. She has had all the important posts in MP IAGE, Indore Obsgynae Society, ISAR, and has been a sought after figure in our state.
Thank you.
Madam, we are honored to have you amongst us in our program. And we would love to hear a few words of blessings from you, ma'am.
Thank you so much. I'm happy. It's too much exaggerated introduction of mine. Thank you so much for that. I'm so happy that you are conducting these types of programs. And I think today's topic is probably the laparoscopic myomectomy, which you are going to deal. And I think laparoscopic myomectomy in last 10, 15 years, 20 years, you can say, has changed the scenario of for the infertility patients, for the all the AUB patients, and for all those patients. So removing the uterus through laparoscopy, I think it's a very, very common surgery. We are not talking or dealing something very special, but still it's very important topic. And I think with all the speakers today, it will be a great help to them. And I think MPIG will like to do more and more programs, Monica, with all those. Will take more and more specialties and take everybody with them. I'm happy to see Meenu over there, Sushmita, Purva, Sonali, Udraj, and Vishal. I think rest of them have not opened their video. So thank you so much. I won't take much time as my nature is that I won't speak much on it. Thank you so much.
Thank you.
Thank
Thank you so much, ma'am.
All the
Thank you so
best.
much. And we are so honored that we started a program with your blessings. And now, as we proceed with the program, ma'am, you will enjoy it because my aim was not to take a simple topic, but to take a topic where, nowadays I was just talking to a few people who my juniors and colleagues and friends, they are paying such a lot of money just to, get training in laparoscopic surgery and going to different centers. That is the current trend nowadays. Still, when they come back and want to start an OT with all the procedures in place, I was discussing with Dr. Sushmita also. They don't know which morcellator to buy. They don't know the energy source. They don't know how to outsource it, fund it, finance it, and how to make it work. So here we are going to catch hold of our experts and basically ask them the troubleshooting. So I'm so thankful for for you to give me this opportunity, Kavita ma'am. And now I come to our guests of honor. Meenu ma'am was the very first one to join us on the show. And I think Dr. Anju Soni just left this morning and she must be traveling. So she might join somewhere in between. Can I
Yes,
have?
ma'am, she is joining.
Yes, ma'am. So I'm so honored to introduce Dr. Meenu Agarwal, who is our distinguished guest of honor for the evening in Synergy 11. Madam is the incoming VP of FOXY 2026. She is the Secretary General of International Society of Gynecological Endoscopy, and she was recently with us in Bhopal for the VPCon. Madam is course director of the international training courses in the UAE at American University of Sharjah. She has more than 15 publications in international journals and has authored 4 books as a first author. Madam is European board certified bachelor in reproductive surgery. She's been awarded by India's Great Leaders by Asia One, Icons of Health by Times Group, Inspiring Gynecologists of West India by Health World, and Champions of Foxy by Foxy. Thank you so much for joining us, Meenu ma'am, and kindly address our gathering for the benefit of
Thank
all
you.
of us.
Thank you, dear Monica, for having me over here. Very kind of you. I think the name Synergy I loved because I think it is a combination of different energies, and that is how you have planned your webinars. You are doing it with IAGE, you are doing it with Maharashtra societies, MP societies, and of course, Bhopal OBGY Society by itself is a very, very vibrant society. So, congratulations to you for becoming the president of Bhopal OBGY Society. And I think these fibroid focused webinars are actually really, really good. And recently, just last month, I was in Germany and I had again pictures with Professor Kurtzheim's chest as well as with his wife and his daughter. So it was really, he was the first one to actually show laparoscopic myomectomy. And then he was told that this is nonsense that you are showing this kind of surgery cannot be shown in the American OBGY Society, and the videos were stopped and all of that. I think everybody knows those stories. And it was really nice to see that if he had been alive today, he would have really would have been amazed the way the laparoscopic myomectomy has taken by leaps and bounds, not only for the surgeons but also for the patient's recovery. Patients go home much faster, much early, and less pain. So, and these small things are important, like you said, which morcelliter to buy, what to do. Actually, TLH is easier than myomectomy when you begin the surgeries. So, very important for the youngsters when to start doing a myomectomy, when should they be confident enough to start doing myomectomies. I can see Dr. Uddhav Raj here, Dr. Sonali here, Dr. Kavita Bapat, of course. So nice to see you. You look good with long hair and short hair both. I can see Radha Lakshmi madam here, Dr. Kunjan here, Dr. Purva here, and Dr. Susmita here, and others I think are not videos are off. So I wish you all the best, and I'm sure your whole program will go very well. All the best to you.
Thank you. Thank you,
Also for your future endeavors, all the best.
Thank you, Minu ma'am. And I just wanted to share, I mean, Sushmita Mukherjee madam just sent me such a, scary picture. When she sent me the picture on WhatsApp, she just operated upon a multiple myoma. The first thing I thought was the uterus was so enlarged, but then I realized the uterus is so small and there was a huge myoma and myomas cropping all over. So now this is the confidence that we have developed over the decades, that you can simply go inside the abdomen and get to operate all these. And this is what we want to teach all our youngsters, that it is doable. If you can think it, you can do it. So this is a saying by one of my teachers, again a very dear mentor who has taught me this: if you can think, you can do it, you can do it. So moving forward, we Dr. Anju Soni will be joining us soon. We come to our special guest, Dr. Purva. You'll let me know as soon as Anju ma'am joins. And we have with us our
Yes.
special guest, Dr. Abha Jain ma'am, President, Bhopal Obsgynae Society. Meenu ma'am, I'm the president-elect. So our president is Dr. Abha Jain ma'am. Has she joined, Purva?
No, she has not joined yet.
Please make a call to her. And I
Yes,
think
ma'am.
Dr.
Done.
Rachna ma'am is there. Has she
Yes,
joined?
ma'am. Rachna ma'am.
Yeah.
Yes, ma'am.
So I will start by welcoming Dr. Rachna Dubey ma'am, who is again a very important figure and a guide for all our programs in Bhopal. She is very active in the government sector of Bhopal. She is the Director Health IEC and State Nodal Officer for Preventive Gynec Oncology and Infertility. Recently, we concluded a beautiful E3 conference by the PCOS Society of India on 9th of March in the city of Bhopal. A very prestigious event for us, which was totally convened and steered by Dr. Rachna Dubey in a very successful manner. Dr. Bapat was there with us with her team from Indore, and we all enjoyed a whole day feast of PCOS. So, madam's passion is PCO. She's also very active in gynec oncology, and she wants to bring the best facilities in the government setups all over in Bhopal as well as all over MP. She has been trained at the Harvard
Ma'am is
School of
coming.
Public
Ma'am will
Health.
join shortly. Sorry to disturb, ma'am. Ma'am is coming. Ma'am will join shortly.
Right. So I've introduced her, and madam will be able to join whenever she is free.
Okay,
So
ma'am.
she
Within a
is
while. Within a while.
very fond of gestational diabetes, mellitus management, adolescents. She has takes a keen interest in adolescent and cervical cancer management. So I will wait for Dr. Rachna to join, and we'll wait for Dr. Abha Jain to join. So coming to next, our coordinators, I would like to introduce the three young gynecologists who have got this program together with me. They are Dr. Purva Bhatkur from the Department of OBGY GMC Bhopal, my alma mater. Dr. Nandini Singh Bhati, again Assistant Professor in GMC Bhopal. And Dr. Gunjan Chaudhary, who is Associate Professor in the Department of OBGY at Chirayu Medical College, Bhopal. So these three wonderful young gynecs will be, taking our program forward. And just a few lines about them. Dr. Purva Bhatkur has got a teaching experience of 8 years. She is a colposcopy training course trainer. She is very active in the state gynecological activities, especially MPOX, where she delivered a first Yuva oration in 2024. She takes keen interest in high-risk obstetrics, preventive oncology, and infertility, and is a prize winner in various events. Welcome, Purva. Next, I would like to introduce Dr. Nandini.
Thank
Dr.
you.
Nandini is Again, Vishal, can you move the slide? Yeah. Dr. Nandini is again very active in the Department of OBGY and GMC Bhopal. Her keen interest is in high-risk obstetrics, antenatal and gynecological ultrasound, reproductive medicine, and gynecological malignancies. Welcome, Nandini. And now we introduce to you our third coordinator who has joined us first time this season, Dr. Gunjan Chaudhary. She is assistant professor in Chirayu Medical College, Bhopal, alumni of Grants Mumbai and Lady Harding, Delhi, with over 10 years of experience. And I think very soon she'll be taking her MRCOG exam. She is a master trainer for Foxy ACS IAP Joint Collab for training OBGY in HPV vaccination and a faculty in several conferences. So welcome, Gunjan.
Thank you, ma'am.
I'm sure you're going to enjoy the first webinar with us.
Yes, ma'am.
Hi, Monica.
Hello, Rachna ma'am. Most welcome. I just
Sorry for being late. Got stuck up.
No, ma'am. I know how busy you are.
कहाँ पर चल रहा है? Where are we? I don't know.
We have introduced all our dignitaries, ma'am, and Dr. Kavita Bapat is there with us, and Dr. Uddhav is there from Mumbai, and the team is there, and we have introduced you, madam, so you can straight away go ahead and a few words about the webinar and welcome Kavita, ma'am.
Arey wow, Dr. Kavita is also there. So many people are there. Love you all.
Thank you, ma'am.
Monica, for giving me this platform. But as you know, March is ending और इतना सारा financial closing होता है. विधान सभा is on. नया center बन रहा है तो actually I know you called me up, लेकिन मुझे लग रहा था 5 बजे पहुंचना है, मैं नहीं पहुंच पाई. This is, you're talking about laparoscopic myomectomy. I know it is such an important topic, although it is very common, but yet very, very complex gynecological problem. And the way we have actually revolutionized is very important with continuous advancements जो हो रहे हैं यहाँ पर, minimally invasive techniques, energy sources, and suturing material. I think we are achieving better patient outcome, reduced recovery time, and of course improved fertility. But it's very important how we select our patients, the suture material, and there are so many surgical complexities also, and case selection is actually very important. So I actually look forward for a very interesting panel or a session, whichever is going on. And thank you for calling me. Thank you very much.
Thank you, Rachna ma'am. And I must appreciate the way the government of Madhya Pradesh has taken steps towards training the government doctors, consultants, and postgraduates. They have installed the best of the, I think, equipment, endoscopy equipment in the medical colleges, as well as Madam is bringing out a state-of-the-art center for fertility, gynecologic oncology, and all these high-end procedures in Kaju Hospital, which is a yes, bilkul. And I'm sure you're going to do a wonderful job and set a benchmark in our state.
Thank you.
I'm sure you're going to enjoy. Dr. Jyoti Mishra, who's doing the panel and troubleshooting for us, is a senior from GMC only. She is my immediate one batch senior, 2 batches senior. And Dr. Uddhav Raj is, from Mumbai. We keep seeing his robotic surgeries, his videos, and today he's, in front of us. And we are just sitting and studying on the eve of Holi. So thank you so much, Rachna ma'am.
Thank you. Thank you so much.
And Purva, now I think you can start the program. Purva, you can start the program. Yeah.
So moving forward, Dr. Vishal, can I have CV of Dr. Monica Singh ma'am and Dr. Randhir Singh sir?
Just names are enough, Purva. Just skip. We are the conveners, and we thank you for the opportunity. So I think we can move. Yeah.
Moving to our academic session 1. That is on tips and tricks of laparoscopic myomectomy by Dr. Uddhav Raj sir. For this, I request chairpersons Dr. Dhaval Bakshi sir, Dr. Shabana Sultan ma'am, Dr. Radha Lakshmi ma'am, and Dr. Kalyani Srimali ma'am to chair the session. Dr. Dhaval Bakshi sir is ASHRAE certified reproductive endoscopic surgeon, gynec endoscopic surgeon, and fertility specialist at Disha Fertility and Motherhood Hospital, Indore. He is a gold medalist and also presently secretary of MP chapter IAGE and a managing committee member of MPSR. We welcome you, sir. Next, we have Dr. Shabana Sultan, ma'am. Madam is presently professor and head in our department, that is Department of Obstetric Gynae, GMC Bhopal. She is presently vice president of Bhopal Obstetric Gynae Society. She has presented various papers and published many papers in national and international journals. And she is member of esteemed team of PPH Bundle and held various executive posts in our Bhopal Obstetric Society. Her special area of interest is gynec oncology and high-risk obstetric. We welcome you, ma'am. Next, we have Dr. Radha Lakshmi, ma'am. Madam is presently working as a professor OBGYN department at Santi Ram Medical College, Nandyal. She had lot of academic experience and she is a gold medalist throughout her PG and UG. She has been awarded Best Doctor Award in 2017 at Kurnool. We welcome you, ma'am, to chair the session. Next, we have Dr. Kalyani Srimali, madam. Madam is presently Senior Consultant Reproductive Medicine at Nova IVF Center, Indore. She is formally trained in reproductive medicine from London, Germany, and also from Mumbai. And she has been trained in endoscopic surgeries under various heads. And we welcome you, ma'am, to chair the session. Now I hand over the session to our chairpersons to introduce our speaker.
Good afternoon, everyone. Dr. Kalyani here. Good afternoon, sir, and good afternoon, Dr. Monica. Thank you for inviting us to chair the session for today. Without wasting any further time, we would like to go ahead and introduce Dr. Uddhav Raj, sir. We all know him as one of the best surgeon in endoscopy. He actually doesn't need any introduction. But to introduce him, he is one of the pioneers in the robotic oncosurgeries, neurogynec and endometriosis specialist surgeries. He is associated with most of the hospitals in Mumbai like Lilavati, Nanavati, Hinduja, Bridge Candy, Jaslok, Fortis, and many other hospitals. He has got more than 25 years of experience, 25,000 plus advanced endoscopies, and 150 robotic surgeries. He's also nominated. He's also with the Limca Book of Records 2012 for heaviest uterus 7.8 kg removed by laparoscopy and many other awards. 100 plus publications and chapters, and he has done more than he has guided more than 800 plus surgeons throughout India and internationally. Welcoming you, sir, for today's lecture, and we are looking forward to having an interesting session on it.
Thank you very much. I would like to thank Dr. Monica, Dr. Kavita Bapat, Dr. Minu Agarwal, and all the organizers and the MP chapter of IIG for giving this opportunity and selecting a very interesting topic. Without wasting too much time, I think I will start sharing my screen. So I think the topic today is mostly the tips and tricks for a minimal invasive approach of myomectomy. And I actually took a liberty of not just doing a laparoscopic, because there can be situations where the combination of coexisting fibroids may come, and that's why I just tried to extend, because that can be sometimes challenging in most of the situations when there are multiple fibroids, or sometimes there is a single fibroid and there can be a discrepant report. So I thank my fellow Dr. Shreya Alluri also for having assisted me for this talk by compiling quite a few films for us. Now, basically, right from the beginning, when we plan a laparoscopic access for fibroid, it goes without saying that we should lay too much emphasis on the clinical history, because the safety begins right then. If we do not do a thorough clinical examination, we might miss a few things, and sometimes we may be taken up by surprise during the surgery. And there will be a lot of factors like presence and absence of coexistence of menorrhagia and dysmenorrhea. This is one of the common things. Many a times we have ultrasound saying fibroid uterus, and it turns out to be an adenomyosis or an adenomyoma or a focal adenomyoma. Also, when we are considering doing only conservative surgery, we have to understand that we have to lay a lot of emphasis on preserving the fertility, or whether these fibroids are reasons for subfertility or infertility, and especially patients who have pregnancy losses with fibroids. So in these situations, we have to understand that we have to take care of the cavity, the uterine muscle, and the blood circulation, and also no compromise of vasculature of the ovarian pedicles and the fallopian tubes. So always lay emphasis on various investigations and not rely just on the radiologist's printed report. I always want to go through the images. And as you can see here, there is a 3D image where you see that there is a myoma, which is at the fundus, but it's of a variable grade. It's extending right up to the serosa outside and also pointing into the cavity. So this is a mixed grade, and sometimes the FIGO grade of classification may not suffice to exactly define the surgical approach of removal of the fibroids. And that time the size, the location, and exact superimposition or occupation of the muscle is very, very important. I had a very interesting case, this one, where the patient presented with a retention of urine, and she was diagnosed as large uterine fibroid. Clinically also, she was in a hospital. And when I went and saw her, I actually advised an MRI because the ultrasound couldn't see exactly into the depth. And when we did the MRI, it was a large diffuse adenomyosis, and it was not a fibroid. Another thing is when we have multiple fibroids, an MRI can give us a certain idea, but now we have advanced 3D softwares which can actually give us a clear-cut, simulation and visualization and mapping of different fibroids, as you can see here. And then we can actually plan the incisions, utilize this kind of information to actually enucleate the fibroid. Sometimes through one incision, we can enucleate more. So we can actually plan so that it's very, very minimally invasive. It saves time, it saves blood loss, and it saves the scars and multiple scars on the uterine body. So here is the another thing, that MRI, when we actually advise to the patient, most of the times we are ourselves not very well versed with the image, and I took special effort to actually go into the details of MRIs. And slowly, when I started going more into the details, I could actually see, say, for example, in this situation, this fibroid is almost a grade 2, going half into the cavity, distorting the anterior wall and the anterior part of the cavity, and also going significantly into the muscle. But at the same time, here at the lower side, there is significant adenomyotic affliction of the lower anterior myometrium. So these kind of evaluations will be very, very important. Vis-a-vis, there can be a fibroid, and here you can see a small fibroid sitting in the fundus, which you might miss when you do a laparoscopy. And this is a large fibroid. And when you undertake such a case, you are bound to miss, which we did earlier in our career, and thought, oh, this is a big fibroid, we did it. And smaller fibroids would be missed. And 4 years down the line, the patient will come back with another large fibroid at the fundus. And here, if you see now, MRIs can actually define more vascular pedicles. And one moment. So then here you can see this is a large fibroid inside the cavity, and there is an intramural extending right up to the cervix, and there is one more sitting down abutting the pubic symphysis and going into the cervix. So such kind of fibroids can pose definitive challenges for performing a surgery. Another situation where you may have a fibroid in the cavity, patient has menorrhagia, and then there is a large adenomyoma with a small fibroid in the wall. So these kind of confusing situations are to be considered when you actually undertake a laparoscopic myomectomy. So surgical considerations is when we plan for a surgery, of course, we have to have enough training with laparoscopic approach and technical considerations. Planning the procedure, fertility preservation is of paramount importance, and especially consent of a hysterectomy becomes paramount when there are multiple large fibroids. And this has to be taken no matter how expert you may be, because at that time patient will be under anesthesia, and even if in the best of hands, this kind of a consent is to be taken to safeguard yourself medico-legally. And then you can decide various approaches. The whole idea of choosing the approach is not about your expertise. It's about how you can reduce the morbidity, make it as minimally invasive as possible, save a lot of time, and also do not give any untoward complications as an outcome or as a side effect of the procedure performed. Say, for example, in the beginning era of laparoscopic myomectomy, large myomas, morcellations and spillage of pieces gave rise to parasitic myomas. And then we became more and more aware how not to overshoot or overkill our judgments and perform what is safe and right for that particular patient. So here, if you see, this kind of a patient sometimes is there, and ultrasound is not actually clearly giving us an idea. There is a fibroid, and during the procedure, when we do a hysteroscopy, you really don't see anything in the cavity. And what I try to do, and now closely watch here, the right anterior wall is protruding. What I call is an intraoperative Lasmar score adjustment. And then I decided, even if this was a grade 4 myoma, FIGO grade, I actually went ahead and incised it and resected it from inside. The moment you see here, I make an incision, the capsule opens and the fluid goes inside. This was a 5 centimeter large myoma, which was going right into the wall. But this kind of surgery, you cannot attempt unless and until you are well versed with the concepts of hysteroscopy, the fluid overtake. And now you see slowly the fibroid keeps popping out. But you have to keep in mind here, a fluid overload is another challenge which you have to keep in mind. So idea is that you can achieve a minimal invasive access to a particular fibroid, but only when you are clear about your expertise, diagnosis, and you know what outcome you are going to give to the patient. So planning the enucleation approach is another important aspect of fibroid. Many techniques have been developed, but I feel slowly in a jargon of multiplicity of different techniques, we tend to get confused and we actually deviate from following the basic principle. So what I follow is always contemplate a right incision, always try to release the fibroid in the right place, keep in mind the blood supplies, and take blood supply control at each small step rather than pulling the fibroid out. That will give a very hemostatic myomectomy to you. Before you undertake the myomectomy, always give due considerations to following points. First is anticipation. Always anticipate difficulty in a case of a larger or multiple fibroid. And a thorough assessment is mandatory. What aspects we should assess is, first is mobility. If there is an impaction, expect difficulty. If fibroids are mobile, you may find it quite easy surgically, or it will not be that difficult. Multiplicity and multilobulation. Another problem commonly occurring during the fibroid is multilobularity, which is rarely diagnosed or defined in ultrasound or MRIs by our radiologists. If you have a very good radiologist working with you, you can discuss and keep innovating the techniques so that when they actually give you a report, you can actually visualize what he or she is saying. And if you know the multilobularity, you can actually enucleate the fibroid without an effort. Location of the fibroid is to be kept in mind, and that will give you the exact guess where to make the right incision and safeguard organs like cervix, IP ligament, fallopian tubes, and of course, ovary. Always factor in the amount of degeneration, because this is also one of the important factors to give have counter traction. If you have degeneration, it's most difficult to actually enucleate the fibroid, no matter what are the sizes, and especially if they are small, more difficult. Presence of adenomyoma, as I mentioned, a coexisting focal adenomyoma or adenomyotic changes in a patient with infertility. If the patient says she has dysmenorrhea, there is a high chance that she has adenomyosis or focal adenomyomas. They may not be fibroids, and they can pose challenges while you are actually enucleating or performing a myomectomy. Another thing is abnormally located fibroids can have distortion and bring bladder above. And sometimes also the ureters can be distorted in cervical and broad ligament fibroids. So you have to understand how to inspect the peritoneum, trace the ureter and bladder properly, develop the spaces, secure the blood supply, and enucleate. And finally, the most dangerous or acute complication can be if you fail to assess the vascularity. And if you have seen that most of these fibroids, if they are heavily vascularized, then they can be difficult to actually. So this fibroid, if you see on ultrasound, on hysteroscopy, it's protruding from the fundus is reasonably, but on ultrasound, the size was more than 10 centimeter. Hence, I proceeded to perform a laparoscopic myomectomy in this case. And this is how we proceed. And careful enucleation, stepwise, controlling hemostasis at each stage, and then preserving. Now you can see the endometrial cavity is just protruding right up there, and such a patient care to take at that time without disturbing the endometrial cavity. You can, that was the portion which was protruding inside the fundus, and you can perform the myomectomy very easily. And such a patient you can actually suture in 2 layers without any difficulty, and then it will give a reasonably good result and scar. Vasopressin we all know, but we actually came across and finally working with multidisciplinary specialists, I finally happened to actually start using vascular clamps in patients with difficult fibroids. And this was a very interesting case. I was called in by a gynecologist who was attempting a suction evacuation in a missed abortion. And it was a very large cervicouterine fibroid with a missed abortion of about 11.2 or 3 weeks. And I said, Madam, we have not done this thing. Well, she said she had a cervical fibroid and we can just do the suction, but the suction cannula couldn't reach. And then in this situation, I said, well, let us do an MRI, defer the procedure because you have called me just now. I am busy. I will not be able to concentrate. And we deferred and we planned this patient another day and we did the MRI. She was a G2P1L1 and suction evacuation failed as cannula couldn't reach the fundus due to the large fibroid extending from posterior lip of cervix, pushing the uterus up to the liver. So our plan was to actually have a laparoscopic approach, safeguard vital structures. And there you see, this is a large fibroid in one section, only the fibroid, 35 by 25 by 16 centimeter, bilobulated so-called O. And here in this section, you can see the pregnancy at the top of the fundus on the right lateral side. So what we did is we put these ports in this arrangement and I used a 12 mm port and I was thinking how to proceed in this case at this time. And here you see the UV fold is completely distorted, brought up, and that's the bladder margin, but bladder also pulled up right above in the pelvis. You can see the fundus deviated on the patient's right side and this fibroid is occupying entirely, pushing the round ligament on the left side towards the left, and lot of congestion in the mesosalpinx and the IP ligament. So in this case, I first developed the UV fold and pushed the bladder down. My idea was to actually expose the uterine supply in whichever way I can access, and did that. And we applied the vascular clamps to the IP ligament and also controlled. So this is the vascular clamp which I use, and initially it was very difficult. Now we have got made the appliers for it, but it's not easy to find. And I used a simple clip applicator to use this vascular clamp over this. So this actually is reducing the blood supply from the IP ligament to the uterus. And once we do this, slowly we started enucleating and it actually goes pretty. You can see the backflow congestion is happening in the on the medial side. And slowly we develop and start enucleating the fibroid. At this point of time, we have not done the suction evacuation, and finally we could actually enucleate and the uterus goes back into the pelvis. At this point, I asked the gynecologist to perform the suction evacuation, and then we could actually exit the case without any difficulty. So this was a very interesting case. But another thing, over a period of time, I did a lot of work on and understanding the vascularity, and now we are using a very innovative method of our own. We use ICG. Now most of the cameras are ICG enabled, and I utilize the similar technique. I see the blood vascular supply to the uterus and multiple fibroids, and then apply the vascular clamps to the IP ligament, and then also dissect wherever accessible the uterine artery. Here you can see the uterine artery is actually skeletonized, and I apply the clips to the uterine artery as well. Now these clips are easily removable. You can have about 30 minutes of ischemic time and then remove. And now suddenly if you see, the ICG disappears because the blood supply is actually at the moment hemostatic, and then you start enucleating the fibroid. Here you can see the capsule has green color, which suggests that the blood supply and the blood vessels are being carried in the capsule. So you can actually perform the dissection and the plane. After 30 minutes, you release the IP ligament clamps and recatch them after maybe 15 to 20 seconds, and then continue the myomectomy. So, so you see the blood loss is hardly anything. And another advantage is once you start closing, this actually prevents a lot of use of energy, because unnecessary use of energy also can be harmful in a case like that. Then you remove all the vascular clamps. And in the end, when we actually see, look at the myometrial closure incision lines, they are green, which suggests that the blood supply is quite good. This helps us to know that the scar integrity can be good or a healing can be good, as it prevents a lot of unnecessary use of energy. It can help in, and this is my own method of doing endo bag rather than that cumbersome, multi-channeled endo bag. I just put all the fibroids in a bag and then start morcellating inside it, which actually saves a lot of time. And so another case of similar type, you can see that we do the same thing, a huge myoma, multiple myomas, all 12 centimeter, 10 centimeter, one lower cervical posterior. So we approach it with the similar method and use only, just two instruments, a good view of camera. If you have a good person who can understand the surgery and show you the camera, it makes things very easy. And once you apply these clips, we follow the same method, continue the enucleation. This saves, initially you have to spend about, and you can see now I have stopped using myoma screws in most of my cases, and all we do is just simply proceed around, and if there is a person who can show you the camera. Another important thing is I've seen many people doing subserosal fibroids directly going at the base and knocking out. I will suggest them not to do it, because this way you actually deprive the myometrium of the serosa, which retracts over it, and the myometrial strength when you try to actually place a suture is very high risk of cutting through it, and that can actually compromise this scar integrity, and the patient may have a high risk of rupture if she wants to conceive. So we leave a lot of myometrium. I have stopped doing those elliptical incisions anymore, because I initially used to think that that can help the good enucleation of the fibroid. So you can see fairly, there won't be much use of, too much, and you can utilize the same incisions. If you have done an MRI, you can proceed and keep removing the fibroids. Make the one incision, you can utilize it to remove 2-3 fibroids, which I'm sure most of us are doing. And slowly more the number of fibroids. Now here is that another right lateral fibroid, which is below the right uterovarian ligament, and it's a multilobulated and a deep fibroid, which is very difficult. And you can see all I am doing is just holding it and slowly enucleating it without the problem of the bleeding or anything. And because hemostasis is under control, I am taking all these specific vessels which have been actually seen under the ICG, and then you can make sure that the bed, once you enucleate the fibroid, the commonest thing is the bed starts oozing badly. Either it can have the venous ooze, or some arteries can retract and they can keep bleeding, and it's very difficult to actually, and most of the times I've seen people using excessive use of energy in the bed to actually achieve hemostasis. So you see now fairly all these myomas are coming off very smoothly without any difficulty. At the same time, it is hemostatic. If you see, there's hardly any blood, because after half an hour, most of your vasopressin effect is going to wear off. This another technique I use. I don't use manipulator ever in any of my myomectomies. If there is a posterior wall suturing required, we do suspend the uterus with a small hitch, and here I am actually releasing after half an hour the ischemic time, waiting 10 to 15 seconds and reclamp, and then just go ahead with your suturing. As far as suturing is concerned, I have now stopped doing all those kinds of fancy stitches, the box and the baseball, because I believe that if you make an incision, you should approximate the edge to its counterpart. And if you don't approximate it to the complementary counterpart, the scar is going to be compromised. Imagine if we can take a baseball stitch on the skin or anywhere else on the abdomen. So I feel that hemostasis, as far as concerned, it begins in the planning of the incision, controlling the hemostasis while the myoma is being enucleated, and after that approximation, straight simple sutures. Of course, if they're deep myomas, you may close in double layer or triple layer as well. That is ideal, and you should be able to approximate. So this is the classic in-bag morcellation. In this case, it is always better to start bagging the fibroids, because if you lose small fibroids in a head-low position, you will have a tough time searching them again, and it's very difficult. So I sometimes thread them together, or if they are very small, I put them in a pouch, in the pouch of Douglas, and then later on remove them together with the bag. So this in-bag morcellation, everybody knows, they have seen enough. Once you remove it through the umbilical port, put the cannula back into the umbilical port and insufflate the bag and remove all the fibroids. So sometimes you may have a situation like this, which is a large fibroid and it's extending right into the broad ligament. However, in this situation, it's not that difficult, but size is quite big, and we may think, and at this time, you may sometimes cut the round ligament. So here you have the fundus here, and this myoma is extending broadly, extending and also stretching the left round ligament. But fortunately, it is purely subserosal and in the leaves. But later on, I find that at the base, it is actually arising from the upper lateral wall of the uterus. So here I am very careful, because then the blood supply from here can be very profuse, and that artery can retract and go into the fundus, and you may end up coagulating unnecessarily. So you can see we go slowly. And as you see in the myoma screw, I hardly give traction. I just stabilize the myoma. So I have realized that we have no need, there is no need to pull. And I take a final blood vascular pedicle, which goes into the fibroid. So this way, you don't have to go back and look into the base. And once this is done, in few cases, I use, if the operating table is a very nice table, I use the suprapubic port to morcellate, and this port usually pains very less. We have come across that the left lateral port is a very painful entity, and later on you can close this incision as you go along. So
So to
please
interrupt,
tell
but
me how
you,
much time. Sorry?
so video is not.
Dr. Uddhav, the video is not playing.
Oh, this one did not play? Oh, see.
No.
No problem. We'll go to the next one. I'm not sure why. Is it playing now?
No, sir.
No?
No, sir.
No, it's not playing.
So maybe I think the internet is slow. I'm not sure why. My internet is quite well overall. Oh. Maybe I stop sharing the screen and go back and share it again. I hope it works.
Yeah, you can stop sharing and then start again.
Yeah, I think I can do that. And just let me see. Is it playing now? No?
No, you have to make it full screen and then I think no, it should play in the normal view also.
Yeah, I'm just checking whether the video is actually
No,
moving
no,
on
it's
your
not.
screen.
You're taking the video from your files and bringing it to here, no?
Yeah, that I will try to do it because if that is
Yeah,
not
it's not
happening,
like
then-
it's not getting
Anyways, I'll play it directly from there. No problem.
displayed on your PPT.
Is the video playing now?
No, doctor, no, it's not.
Because I am playing directly now from my this thing. I'm not sure.
We have-
Anyways, I will just conclude. A few other slides are there. Let me see if I can play the other videos. Maybe there is an issue with that, or it's a heavy file, so sometimes there may be a
Yeah,
problem.
now we can see this. Now we can see that video symbol, but the video is not playing.
No, I
There
think now I've stopped the video. There is a lag, I think. There is a lag. I have moved on to the slide actually now.
Right.
So, yeah. So can you see my slide now? On a robotic myomectomy slide?
Yeah, the slides are visible.
Slide are visible. Okay.
Yes,
So
they are
anyways,
visible.
we will go on this. So now this is another case. This was huge multiple large fibroids in a 36-year-old P1L1 and more than 17 fibroids she had. As you can see in this particular area, there are 8 to 10 centimeters, 7 centimeter, all clustering around and anterior wall filling up entirely. There were 3 to 4 submucous fibroids as well. So this patient we planned the similar approach we converted from the lab to the robotic, and this actually makes it very less tiring in robotics. And similar approach we apply. We put this is Scanlan hemostatic clips which we apply. So that helps in actually controlling the blood loss. And you can see fairly when you enucleate the myomas slowly. Advantage in robotics is that you can have dual energy at your disposal and both hands work complementary and contralateral to each other like you can do normal. And that actually is a good physics to have enucleation method. And this way you can, is the video playing now?
Yes, it is playing. Yeah.
Okay, great. Okay, so this is embedded in the slide, so it's playing. So good. So this is, so you can see as we remove one fibroid, there is another sitting down there and we keep going this way. And I'm hardly using the traction of the myoma screw, or myoma screw is only used to anchor and give gentle stability so that you can use energy and dissective movements with micro progress. So even if you progress slowly, it is fine because it is hemostatic in its entirety. And this way, a multilobulated fibroid also you can slowly enucleate. The beauty of the laparoscopic robotic instruments is you can use them like fingers. And of course, there is no haptic feedback. That's a disadvantage. So it's a little bit of a challenge in the beginning. Another advantage is that the camera is in your control. So you can actually control the vision entirely, and you'd never go out of vision. So that actually saves a lot of time. And as you move forward, now this fibroid, if you see, has completely degenerated. So my assistant is trying to give it traction, but it just tears off. So in this, I've just did not, I stopped seeing the fibroid as my target, and I just tried to go into the base of the fibroid and slowly kept moving and mobilizing the incision and securing the vessels at the base. And slowly the fibroid came off without too much of fight, because such a situation is quite complex, and this is very irritating while you do complex myomectomies. But if you see, if you note the bed, it is bloodless because we are actually working in complete hemostatic control. So this becomes truly minimally invasive. And if you see the end picture, from where we started, there is a very good hemostasis, and you place the adhesive barriers, and this patient recovered also very well. We did not have to transfuse any blood. Overall blood loss in this case was about 200 ml, which for me in such a case is not less than 800 ml if you continue doing this throughout. So I think these methods have actually helped me to reduce the morbidity and also reduce the blood loss. Also towards the end, if you see, we can then close these myoma beds with robotics, which is not that tiring as compared to laparoscopy. And then you use ICG to check the vascularity of the bed. You can see the vessel supply, so that it proves that we have not used too much energy there, which can cause necrosis. And towards the end, you can again reapply or remove the clips as you wish, once you are sure that. So in this case, now I'm dealing with the anterior ones, and this is how we've continued and finally removed all those fibroids one by one. So I think broadly, then there will be certain situations where you should put your foot down. And that is something where if you have too many and small fibroids, they can be very, very tiring, or large fibroids. Then, or sometimes the abdomen is weird. Patient is very obese, which can put a lot of strain on your hands. This kind of a patient, then I use something known as a Surgisleeve wound extractor. Make a small mini lap, which is about 4 centimeter, extendable to 6, and you have different sizes available. It protects the abdominal wall, and you can actually remove. And in this situation, sometimes you can exteriorize the uterus and also suture the uterus, so that it does not put the strain on your. Because if the procedure goes beyond 3 hours, it's boring for everybody and it's risky for the patient. This was a very interesting case, bicornuate uterus with fibroids in both the horns. So this patient had to preserve her fertility as well, and needed this uterus to be preserved and wanted to conceive. So we did myomectomies in both the horns. Similarly here, large multiple myomas, many sols. When we did the MRI of this patient, there were so many smaller myomas that we thought we should not spend time in laparoscopy in this patient. So we did this, exteriorized the uterus, closed the beds, and then reposited the uterus. In some special situation, you can have this lantern on the St. Paul's Cathedral type of huge fibroid also protruding into the vagina. Of course, this patient was not a myomectomy, but here you can see the bladder advanced there, and devascularization of the uterine artery and the blood supply immediately makes the uterus very, very cyanosed, and you can do a safe surgery, conserving the ureter and the bladder. Parasitic myomas, of course, very, very complex. And this myoma actually had entered the abdominal wall and the rectus muscle. So we had to suture it and put a mesh there. This patient, but fortunately, she did well. So I think now in today's times, we need to be very careful. Certain fibroids are directly in the anterior, more into the bladder vesicovaginal space. So you have to be very careful. Here you can see a very thin cervix in this patient. Of course, she was for a hysterectomy, not a myomectomy, but these kind of situations can be there. Now, when not to do morcellation or proceed with a myomectomy, I had this patient, 36-year-old, but infertile, and I asked her to do an MRI. She refused. Her 24 to 36, 24 to 28 weeks uterus was the size per abdomen. But when I went in, I saw this, and I actually abandoned. I did not touch this patient. And later on, she went to somebody because she was very, very keen on having a surgery, and they had a lot of problem during the surgery. They had to transfuse 6-7 bloods to this patient. There was bladder injury, and this patient ended up with a hysterectomy. So I was glad that I did not proceed on that day for this patient. This patient was a post-menopausal lady with a large fibroid, and they came for a hysterectomy. This patient, this fibroid was coming from the left uterosacral, and when I saw its surface, I was not happy. I said, we are not going to be, it's a post-menopausal woman, we will not morcellate, and this came out to be a leiomyosarcoma. So these are the few situations where we have to be very careful. In few years, we will have something known as 3D models, which can give us, yes, and here you can actually simulate the myomectomy before you go in, and actually also have the a guess of the blood supply, which is very complex in a uterine myometrium, something like a liver. It's not an end artery organ, and hence these kind of things can actually be the future of making these surgeries more and more minimally invasive. So simple take-home points: we have to have careful and accurate diagnosis. I will not actually elaborate too much on the suturing, because I feel that suturing is, my simple principle is approximate the myometrium, the complementary counterpart of the myometrium to each other, and do multiple layer suturing wherever required. That is very, very important. So careful and accurate diagnosis is a must. Choosing the right approach and the right team you should have. Keeping the uterine vasculature, tubal anatomy, and cervical anatomy always in the mind. Mastering hemostatic techniques. This has changed my approach, and now I don't have to apply too much traction, force, pull, and push in fibroids. And I find that actually the myomectomy techniques have evolved. Good suturing and reconstructive techniques are to be mastered. Bladder and ureters, whenever the fibroids are encroaching in that area, they should be safeguarded at any cost. Morcellation, you should know when not to do, and when, if you are doing, when to do contained and open. And combination of techniques, and still we try to be minimally invasive. This is ultimately very, very important, that sometimes you can choose a mini lap and deliver the fibroids. So thank you very much. I will conclude my presentation.
Thank you, Dr. Uttar. That was a wonderful talk. And before we have the comments by our chairperson, Dr. Anju Soni has joined. Dr. Anju Soni, madam, is VP Elect Foxy 2026, and madam is traveling, but she has taken pains to join the program. Ma'am, we have already spoken your slides, so we would like to have a few words of blessings from you, ma'am.
Thank you, dear Monica. And you are a real star. You have been doing a lot of academic activities. And I'm sorry I missed Dr. Kavita and dear friend Rachana and Abha. I hope she's there. And of course, my dear friend Meenu. And it's very heartening to see you and your husband working so hard. And today's program is a complete capsule for myomectomy. We all know that myomectomy is today a very important surgery, which has a total, different kind of, complications to itself. And it is all up for us. It's really important for us to know where to go, how to go, and build the expectation according to the diagnosis, not according to patient's will, and give complications. I just heard a beautiful lecture given by Dr.
स्ट्रेस लेवल आया है
And
उन सबको चुका के
Dr. Uddhav,
Dr.
Dr. Uddhav Raj.
Uddhav Raj, and of course all the chairpersons. It's been great listening to him. And you have again kept a very beautiful panel. We should discuss the other points which have not been covered in this program. And I want to wish you best of luck for all your future endeavors. And I'm sure that today's webinar CME will definitely benefit lots of people, because practical experiences working behind the scene is very, very important, and learning few tips and tricks from seniors for people who are working is very, very essential and crucial. So thank you for inviting me, and always there for you, darling, and congratulate you for the beautiful education you are taking throughout.
Thank you.
The
Thank you so
best wishes
much,
there.
ma'am. And thank you
Okay.
for taking out the precious moment to be in our program in the midst of your travel. Have a good holiday, madam, and have a very great Holi. And we would also like to invite.
My holy wishes to all the people who are present here today.
Thank you, ma'am.
So,
Same to you. And I think
so-
Dr. Abha Jain is also joined. Madam is our special guest. Dr. Abha, can you hear us?
supposing one business
Madam, can you hear us? Madam, please unmute. Madam, please unmute yourself. Madam, kindly unmute so that you can speak to us.
Hello.
Yes, yes. Good evening, ma'am. Good evening.
Good evening.
We just finished 1/3 of our program. 2/3 is left. So it is a good time to join, madam.
Okay.
Welcome to Synergy with BOGS and MPIAG, ma'am.
Okay. Continue.
Okay, ma'am. Thank you. Thank you so much. So I would like to invite our chairpersons for the comments on the lecture, the beautiful lecture. So Uddhav Raj, sir, I would like to just ask one question, like you're using the vascular clamps now. So you're not using vasopressin at all? Or are you using vasopressin in combination with those vascular clamps?
Actually,
No,
with the vascular clamps, it is not required only.
No, so what I do is, there is something very important that when we take the uterine arteries at the isthmus and IP ligament, then there is one supply which is from the posterior division through the vaginal and the vesical arteries, which still continues to the uterus, and there will be some amount of vascularity, which I intend to keep. So to control that, if you have fibroids in the lower side of the uterus, then I would still go ahead and infiltrate vasopressin to actually give vasoconstriction in the vaginal vessels. But if you have fibroids more towards the fundus or in the upper body of the uterus, then I usually don't. But I instill plain saline, which is largely to actually exsanguinate the patient. Because in these clamps, I am usually taking precisely the artery and allowing the venous return back to the patient. So I infiltrate saline. So when there is a huge fibroid, usually there is about 250 to 300 ml blood already in the uterine body or the myometrium and the circulation or the sinuses. So this way we tend to have a lot of intangible blood loss, which we cannot measure. And that is the reason that I actually exsanguinate the patient, then proceed with the myomectomy. This makes the myomectomy very, very smooth and hemostatic, as you see.
Thank you. Thank you so much for that answer. And it was a beautiful demonstration of all the procedures that you have, the innovations which you have done in your own technique. You must not be remembering, but I trained with you long back in Prince Ali Khan Hospital where you were faculty. So
No, madam, I very well remember.
So-
I am not trained many people. So I remember every one of them. Thank you very much.
So, I mean, there were so many good things in your lecture. You talked about robotics. You talked about that greenish blue dye, that intravenous, which actually colors up the tissue in such a way that you are aware of your surgery and the demarcations.
Yeah.
You talked about vascular clamps, which are available now in every conferences. You can get those clamps very easily, very easy to buy,
Yeah.
cost effective. So I think they should
Yes.
they form a part of integral part of this surgery.
Yes, yes. I encourage people to actually have a cadaver workshop for obstetric hemorrhage. After doing this, I realized that actually obstetric hemorrhage is one of the nightmares for the whole country. And Foxy and everybody is doing so much to actually improve the morbidity and mortality, especially in the rural areas where the rates of obstetrics are very. I realized that using these vascular techniques, we can actually save a lot of women and also avoid unnecessary obstetric hysterectomies, sometimes which we have to undertake in the situations where we have less resources. So simple applying the vascular clamps can give you a lot of time. So it just does not have a use in myomectomy or a complex gynecological surgery in huge uteri, but also in obstetrics.
Right, right. So for introducing the vascular clamps, you will have to do a mini lap, right?
No. Introducing vascular clamp, as I showed you in one of the breaths, at 12 mm port is enough. Now I have made a smaller vascular clamp, which is actually used by cardiac surgeons. But unfortunately, in the beginning, cardiac surgeons use it for coronary arteries. So what I did was I modified them to the size of our uterine artery, which can be from about 2 mm, especially at the origin, to about 4 mm. And this was the important, and length was very important, because another problem in the uterine arteries, it's not like visible, like say for example, if you have to do a appendicectomy, you can actually see the appendicular artery, or a gallbladder end artery organs, you can actually do direct visualization of the artery by dissection and clip them, or you are doing. So I found that it was easier doing a nephrectomy or a gallbladder surgery than a hysterectomy or a myomectomy. And the reason simply was because uterus is massively vascular, and it is supplied. It's like a circle of Willis in the brain. You have a pelvic vasculature. So that is very important.
Vishal, you can mute. Vishal, you can mute other parts. Yeah. The studio can mute, yeah. So
so that is the advantage.
Yeah. Great. So that was really a very wonderful lecture. Would the chairperson like to conclude the talk? Dr. Kalyani, Dr. Shabana, Dr. Would you like to conclude the talk? Or shall we move to the next?
Ma'am, you are muted.
Thank you so much, Dr. Uddhav, for being with us today. And we really appreciate your time and the skill with which you have, done all these procedures. And I'm sure you're going to just reach the topmost level of this surgery. And, your techniques are going to become more and more popular because of this webinar. And so many people.
Thank you very much. Thank you very much, madam, for the chance and opportunity.
Thank you.
Like to meet you again, and you're all welcome to Mumbai anytime in our OR with us to enjoy the experience and share your thoughts. Thank you very much.
Thank you. Thank you so much, Dr. Uddhav. And we will surely see you live, operating live, and we will have you in more of our endoscopy programs in the near future. So now I hand over again the session to Dr. Purva to conduct the panel now.
Thank you so much, ma'am. Thank you so much, sir, for wonderful. Now moving to our most awaited session on panel discussion, tackling difficult situation in laparoscopic myomectomy. To moderate the panel, we have with us Dr. Jyoti Mishra, madam. Madam is presently Director and Head Advanced Laparoscopy Robotic Surgery in Yatharth Hospital, Noida Extension. She is dedicated laparoscopic surgeon since 28 years. She is presently Treasurer UPIAG, Director in Excel Academy of Laparoscopic Training, and also she is a trained Foxy laparoscopy endoscopy trainer. Also, she is a very active member in Foxy. We welcome you, ma'am, to moderate the panel. Next, we have with us Dr. Shushmita Mukherjee, ma'am. Madam is our expert for the panel. She is presently Managing Director, Dr. Shushmita Mukherjee Fertility and Laparoscopy Clinic. She is life member of FOXY, ISAR, IFS, IMS, IAG, IMA. She is national faculty at AICOG, IAGA, IFS, ISAR. She has received IFS MP Star Award, ISAR Dronacharya Award. She is a gold medalist and presently Executive Committee member IFS and IAG MP chapter, organizing committee member ISAR, IAG and AICOG. Well, we welcome you, ma'am, and looking forward for your valuable inputs. Now I hand over the session to Dr. Gunjan and Dr. Nandini to introduce our panelist. Dr. Gunjan.
Good evening to one and all. Moving to our panel discussion, our Moontop panelists. First panelist is Dr. Anupama Gupta, madam. Madam is a senior consultant gynecologist at Fortis Hospital, Shalimar Bagh, and she's also the chief gynecologic surgeon at the Ridge IVF Center. Moving to our next panelist, Dr. Atisha Jain, sir. Sir is the consultant laparoscopic surgeon at the Asian Institute of Infertility Management, Indore. Moving to our next panelist, Dr. Divya Sharma, ma'am. Dr. Divya Sharma, ma'am, is consultant at the Tulip Women's Laparoscopy and Daycare Center, Kolar, Bhopal. Moving to our next panelist.
I think you can introduce alternate panelists.
Yes.
Nandini?
Yes, ma'am.
Yeah, fine. Go ahead, Gunjan. Yeah.
Yes, ma'am. Now, the next on the panel is Dr. Divya Singhal, ma'am. She's the National Coordinator, Breast and Pupil Committee, FOXY. And ma'am has achieved various awards like APJ Abdul Kalam Excellence Awards, Pride of Delhi Award. And ma'am keeps a special interest in prevention of breast cancer and cancer cervix. Next panel.
Next panelist. Please go ahead, Dr. Gunjan.
Yes, the next panelist is Dr. Harshal Shah, sir. He's Director, GARDA IVF and HD Women Care, Indore. And sir has done MBBS from Baroda Medical College and MS from NHL Municipal College. Sir has completed his fellowship in infertility, minimal access surgery, advanced hysteroscopy and laparoscopy. He's a proud member of IAG, FOXY, ISAR, ASRM, ASHRAE, PCOS. And sir has various paper presentations to his credit, and he's also awarded Young Brigadier Award at UVA ISAR 2024. Next.
Our next panelist is Dr. Kanika Jain, madam. Madam is Secretary of NACHI, Delhi. She's also the minimal invasive gynecologist unit head at Sri Gangaram Hospital, New Delhi. Moving to our next panelist.
The next panelist is Dr. Mudita Jain, ma'am. Ma'am is Professor and Head of Department Ops and Gynae, RKDF Medical College, Bhopal. She has been past Secretary and Treasurer of Bhopal Ops and Gynae Society, also the past Joint Secretary, and an Executive Member of MPOX 2015. We welcome you, ma'am.
Moving to our next panelist, Dr. Nidhi Nagar, madam. Madam is currently consultant gynecologist and laparoscopic surgeon at Bansal Hospital, Bhopal, with a special interest in high-risk pregnancy, urogynecology, and complex laparoscopic surgeries. We welcome you, ma'am. Our next panelist, please.
And our next panelist is Dr. Sandhya Gadre, madam, and she's especially delighted to introduce ma'am. She's my mentor. She's currently professor and unit head in Obs and Gynae Department, Shirayu Medical College, Bhopal. Madam is a passionate clinician, academician, and also a very good laparoscopic surgeon. Madam has experience of more than 19 years, and she's the chief coordinator in medical education unit and a research faculty and methodology workshops. Next.
Our next panelist is Dr. Sonali Agarwal, madam. Madam is currently the director at Agarwal Hospital and Research Institute in Gwalior, and she's the executive member of Indian Fertility Society. Moving to
Our next panelist is Dr. Sonal Srivastava, Madam. Madam is laparoscopic surgeon and IVF specialist. Madam is consultant at Lake City, Bhopal, and Madam has done various fellowships in endoscopy, IVF, and endometriosis, and she's specially trained for retroperitoneal dissection and has presented many papers at national conferences. Next.
Our next panelist and panel for today is Dr. Tabassum Dalla Madam. Madam is currently director at the Zubista Hospital in Raipur. She is also the vice president of Raipur Menopausal Society and has held various executive posts in Raipur Obsgynae Society. We welcome you, ma'am.
Now we hand over the session to our panel moderator, Dr. Jyoti Mishra, Madam.
Didi, you are muted. Jyoti Didi, please unmute.
Are you able to hear me now?
Yes. Yes.
Yes, ma'am.
Good evening, everybody. There's some problem, so I'm talking through my phone and I'll be sharing my slides through the.
Yeah, but you are audible clearly.
That's good. So thank you, Monica, and all your team for this wonderful program that you have organized. Before wasting much time, let me start sharing my slides. And I'm glad there are so many wonderful panelists. They're all very advanced surgeons, I think. 1 minute. 1 second. Let's share again. Share.
I must tell about Dr. Jyoti Mishra. She was one of our most beloved seniors in college when we were doing post-graduation. Always helpful, always lending a helping hand and very loving towards juniors. And we learned a lot when we did post-graduation together. In fact, I was her immediate junior.
Thank you, Monica, for the words. Can you see my slides? And can you see?
Yes, we can.
Yes. So I think after Dr. Uddhav's lecture, a lot of doubts have been cleared, and it was quite lightening for all of us. So let us move ahead with after the introduction. Fibroids, we all know, are most common. We all see fibroids almost every day in our OPDs. I have made the presentation case-wise, and few are specific situations. Yeah. So Mrs. SN, 35 years old lady, P2L2, presented. She had previous to normal deliveries and a history of normal menstrual cycles. She just came to emergency with loose motions and vomitings, where they did a whole abdominal ultrasound, and what they found was uterus with multiple fibroids, the largest being 5 into 4 centimeters. Her ET was 8 millimeters. She was given treatment for loose motions and vomitings, and then she was sent to the gynecologist. What next? My question is to Dr. Atishay Jain. Dr. Atishay. Dr. Atishay?
Yes, ma'am. Can you hear me?
Yes, we can.
Yes. So, ma'am, since her symptoms were not related to the fibroid anyway, so there are multiple fibroids. So we can counsel her and tell her that since she is just 35 years old, we can just monitor again, and if she has any symptoms of related to the fibroids, we can give her an option for a surgery. But I think medical management would play a better role in this case for now.
Okay, and Dr. Anupama, do you have to say?
Hello.
Have
Can you hear me? Hello. Yeah.
Yes.
See, the patient is having, although it's a mild dysmenorrhea, so I would still be on a lookout for a submucosal fibroid. So probably I would advise her to go MRI for fibroid mapping, just to see what the location of various fibroids is. So although otherwise she's asymptomatic so far as the fibroids are concerned, so investigation wise, I would still want to do that. Now, 5 centimeter fibroid, and if she's not asymptomatic and dysmenorrhea is manageable, then we can just keep her on medical management, giving her option for myomectomy at the same time.
So we have a lot of panelists. We can't take view of everyone. I think we'll ask one question to 2 or 3 of you. Dr. Divya Singhal, do you have anything else to add? Would you like to go to MRI, or you will just counsel her? She has completed her family. She says, I have no problem. Why do I do it?
Yes, she has completed her family, as we see, and she has no symptoms. This is just by chance that we've noticed the fibroids on ultrasound. I think we can leave it at this, but she definitely needs to come back every year with a fresh ultrasound, a TVS, because this was just a TAS ultrasound. So better if we have a TBS ultrasound at least, and tell her that in case she has severe dysmenorrhea or severe bleeding, then definitely it could mean that the fibroids are increasing in size. So all those things have to be told to her and just wait and watch.
So the take-home message would be, it's very important to do proper case selection. This webinar is to let you know about all aspects of how to deal with a patient with myoma.
I would also, I would just like to add that in her case, we would like to have a family history also. That's very important because just in case she has a very strong family history or a family history of malignancies or maybe sarcomas, so that needs to be taken care of. And plus, the ultrasound KUB and the kidney functions need to be seen. Because if it is large, nobody has done a PV on her. I mean, we were not told about the findings. So these are just multiple fibrous, largest being that. So clinically, we have to assess how big is the uterus. That's also very important.
Patient is important. Maybe if you feel it's
Transvaginal scan and fibroid mapping. That is very important.
Exactly.
very
So
important.
then only can we prognosticate or tell her what exactly she needs or what exactly needs to be done.
Counseling
if they're
is very
all
important.
sub-serous and intramural and maybe the size is less than 12 weeks and she's asymptomatic, no significant family history, yes, we keep her under observation. Otherwise, we may need to intervene depending upon the findings.
And if she's keen to have another baby, then what is the prognosis also that we have to decide?
Yeah, so that's what we've started with, a very simple decision making thing. That is very important to take into account her symptoms, age, fertility, desire, medical. Of course, a complete clinical examination is a must before we start doing investigations. And what matters is, because we all get references, fibroid higher 2 centimeter, and the gynecologist has to see the patient. Size, location, number, type, relation to surrounding structures, all these things will help us in making a decision. Now let's move to a slightly more complicated cases. Mrs. SM, 39 years old. She has 2 children, normal deliveries, cycles are regular, mild dysmenorrhea. When we ask, then she says, but she's not troubled by that. No other past history. But for the last 6 months, she started having heavy periods with clots and moderate dysmenorrhea. She finds a change in her pain for last 6 to 8 months. Ultrasound shows uterus with multiple fibroids, intramural and subserous. The size ranges from 2 to 4 centimeters, and the largest is 7 into 6 centimeters, pressing on the endometrium. The cavity is distorted. Uterus is about 12 to 14 weeks size, irregular. What next? My question is to Dr. Harshal. Dr. Harshal Shah.
Yes, ma'am. Ma'am, in this case, as patient is 39 years old, and we have to do a fibroid mapping. Now, in this case, the advice would be to go, if we're going for surgery, would be hysterectomy. So probably we see the hemoglobin level of the patient, and we correct the anemia if it is there. The patient's family is complete. In imaging, I think the transvaginal ultrasound is enough, because I won't go for an myomectomy in this patient. Patient is not desiring a fertility. The USG will suffice in this transvaginal.
Let me first take you to this slide, because this was later. This is a very important slide for everybody who's watching this webinar. Myomectomy or hysterectomy. Now you all know that under 40, we are all under scrutiny, all under camera. Hysterectomy with or without BSO in a woman less than 35. Hysterectomy with BSO in women less than 40. Any procedure where is not properly mentioned in the records, or your histopathology doesn't match with your indication. So there's a Supreme Court order that any woman who is under 40, that's why I kept the age as 39, because this is the clinical scenario we all come across. Patient says, Doctor, nikal do sab kuch. But then we have to be very sure that what we are doing. Best would be to take a written consent in Hindi in her language on a separate paper, telling her all the consequences of recurrence, etc. Now, my next question is to Dr. Nidhi. Dr. Nidhi, what imaging studies would you do with this patient? Before deciding about the line of treatment, you would want to do some imaging. Dr. Nidhi Nagar.
I don't think she has joined. Jyoti Didi? Nidhi is not there. Yeah.
Mudita Jain.
Yeah,
Yes,
Mudita.
ma'am. I would like to do her TVS followed by an MRI mapping as her age is less. So all the fibroids should be mapped. Which fibroid is giving the symptoms and which is not giving the symptoms. After mapping of the fibroids, we can counsel the patient and then we can proceed for the procedure. So for me, transvaginal ultrasound followed by MRI mapping is a must.
All right. So ultrasound, we always prefer ultrasound as the first line of investigation because it is easily available and many a time gynecologists themselves can do. Saline sonography in suspected cases of submucous myoma, and is not operator dependent. Here you get the film, so everybody can read the film. And sensitivity of MRI is more in giving my fibroid mapping. One is we all have over the years learned how to read MRIs because they were not there in our time. So all the planes are very important. By this, you can actually make a mental picture of where the fibroid is. For example, this is at the fundus. In the coronal plane, I can see it here towards slightly to the left. In transverse plane, I can see it more anterior. So putting together all the planes is very important. Contrast may further benefit. Dr. Mudita Jain has Dr. Sonali Agrawal. What treatments will you offer her? 39 years old, largest 7x6, medical, surgical, myomectomy, hysterectomy.
First of all, we go for the investigation. If there is anemia, if hemoglobin is really low, when we would prefer the medical management and we will improve the hemoglobin and then see. And then counseling is very important. If it is like she continues to bleed and she's having menorrhagia or menometrorrhagia, we can go for the surgical management for this patient.
Dr. Sushmita, anything you would like to comment?
Yeah. In any of these patients, I would always prefer to do a scan myself, a transvaginal scan myself, and get an idea about the number, the location, and everything. And I prefer to give the patient a pictorial idea about the lesions. So that communication and counseling with the patient helps us to give them a clear picture about the pathology and the future management and what are the implications and everything. So that is how I prefer to deal with such patients. Because they don't understand MRI, sometimes even they don't understand ultrasound. So it becomes very easy to make them understand and take consent for whatever I am planning to do.
Yeah. So I would say that such a patient, 7 centimeters, quite a large fibroid, and she's only 39. She has many years of menstruation. This is likely to grow and the surgery may become more complex and her symptoms may increase. So
Well, in some cases, even Mirena can be suggested. And even in patients with multiple fibroids, sometimes that also works.
Yeah. I have
But
written that.
fibroid should not be distorted, madam, for dissection of Mirena.
May I give my opinion?
It is there.
I say something over here.
It is distorted and it is, even on the field, the uterus is irregular 12 to 14 week size. So usually 12-week size Mirena tends to come out or come down in the lower segment. So let us say Dr. Sonil Srivastava, suppose a decision for myomectomy is made, for example, in this patient, you decide that all the bigger ones you will remove. What preparations you would do, like tomorrow is your OT, what preparations mental and to your staff you will do in these cases?
Ma'am, first of all, we pre-op check up the PAC that the hemoglobin is adequate because there is high chance of bleeding, and all the vitals like chest X-ray, ECG, and everything is perfect to take up the anesthesia. And then bowel preparation is also important. We're going for laparoscopic. And NBM, ma'am.
What bowel preparation would you like to do in this case?
Ma'am, 2 tablet Dulcolexes at night.
Just want the bowel to be clean. Yeah.
Yes, ma'am.
Okay, so let's go to the OT now. The next morning comes and the patient is in the OT. This is a typical setup. The positioning of the team and the extreme head low, whatever best we can give in our OTs. Are there some special equipments you will keep, Dr. Divya Sharma, for this case of myomectomy, like routine bipolar suction? Or for myomectomy, what all extra instruments would you like to keep in the OT? Dr. Divya Sharma. Is she there?
Myoma
myoma spiral is a routine part of my laparoscopic trolley. So I would like to use a myoma spiral as well as a laparoscopic tenaculum to give traction to the larger fibroid. And harmonic is a tool that I regularly use to dissect the myoma from its myoma bed. I am expecting a 7 centimeter myoma, which is submucous. So I'm expecting the endometrial cavity to open up. So I would keep sutures accordingly. Maybe a barbed suture would be more helpful because multiple myomas have to be removed. So we need to be fast. I would also like to keep injection vasopressin ready when I start dissecting the fibroid. So these are the tools that I would
Very
go
correct. Aspiration needle,
Endovag. Endovag would be required.
tenaculum, morcellation.
Endovag and a morcellator.
Yeah, so this is a picture of whatever you said was correct, an aspiration needle as well. And we usually keep extra set of spirals because sometimes they tend to break, they tend to bend during a large fibroid. So I think every OT has extra sets of myoma spirals.
Ma'am, about 10 years back, there was this huge noise about fibrosarcomas appearing and in-bag morcellation. But in further research, in-bag morcellation is not something that needs to be done in every case. So it
Talking of in any, usually this is the setup we all keep ready. A morcellator usually we keep for a 7 centimeter fibroid. We have cases regarding everything. So,
right.
Dr. Kanika, when you have multiple fibroids, what all kinds of challenges do you anticipate?
Dr. Kanika, are you there? Dr. Kanika is there?
Bolo.
Okay.
We can go to next panelist, Jyoti Didi.
Madam, can you answer this? Multiple fibroids, Dr. Sandhya Gadre.
Dr. Sandhya, madam.
Ji, Dr. Sandhya. Multiple fibroids, what all challenges do we face as a laparoscopic surgeon?
Madam, you're muted. Madam, please unmute.
See, multiple fibroids is really a difficult situation. There are many challenges we can come across. So specifically before going in for the surgery, as we have already discussed, that we have to do a good fibroid mapping. We have to see in which locations are the fibroids available, are the fibroids are present, what is the size and how many numbers we are supposed to remove. So multiple fibroid can make challenges. Suppose they are multiple in number specifically, the first and foremost thing, as we are aware that it can cause a lot of intraoperative hemorrhage. Then if they are in the broad ligament, the ureters are likely to be affected. We are likely to injure the ureters while we are operating upon. If they are anterior or in the lower segment or cervical fibroids, the bladder is likely to be endangered. So we have to be very careful while we are planning our incision, while we are taking out the fibroids one by one. So we have to know which fibroid we are removing. Accordingly, we have to safeguard that particular area. Like for broad ligament, we have to see where are the ureters, the location, and we are supposed to enucleate the broad ligament fibroids from the medial side, from more towards the uterine side, so that the ureters are safeguarded. Of course, after vasopressin injection. And if bladder is riding over the cervical fibroid, we have to see that the bladder is properly reflected down, and then only we go ahead for removal of the cervical fibroid. So these are the situations which are literally challenging at some times.
And we also sometimes don't find some fibroids are missing. We are not able to localize those fibroids. That also is a problem sometimes.
Yeah, that's also is a problem. And of course, we have to go ahead with laparoscopic myomectomy, even for that matter, open myomectomy with a consent of hysterectomy. Sometimes if the bleeding is not able to be controlled, we may have to switch over to hysterectomy. So this counseling has to be done very well before we switch over to the procedure of the myomectomy.
Dr. Jyoti, I just wanted to add something. In a case of multiple fibroids, first of all, mapping is very, very important. And your plan of surgery, you're not going to take out all the fibroids which are there. that see the problem of the patient. If we are like it's a very small fibroid, then you are not going to touch it. So mapping and your plan of surgery before the surgery is very, very important. And if they are nearby, then we
If the
can think of-
fibroid is small, if what I differ here, if the fibroid is very small, today it is small, but in the future time it is likely to increase in size and
Yeah,
give
that is the part
try
of
to remove as
counseling.
many fibroids as you can.
We have to
Yeah.
And that too with a single incision, if we have to plan our incision in such a fashion that minimal incisions, or maybe sometimes it is possible for us to remove all the fibroids from a single incision.
Yes, Dr.
That
We
yeah,
have
that we can do. With the one incision, we can remove maximum fibroids, but if they are like not creating any problem, and we can counsel the patient that each and every fibroid is not, we are not going to remove. So
first
that is very important point to counsel the patient beforehand.
and tailor type 3, 4, which are small in between, you cannot see them hysteroscopically,
Right.
form a bulge laparoscopically, and digging holes everywhere is not advisable.
It's not advisable.
So we have to counsel her that maximum, maybe after 3 months she can go for an IUD insertion. So how will you ensure removal of fibroids? Dr. Sushmita, I would like to ask.
We can put a bag beforehand and keep it in the pouch of Douglas. Ready. And one by one, we can put the fibroids, or we can thread in all the fibroids.
Question is, any role of intraoperative ultrasound to see anything is left, like any major 4-5 centimeters left in the ball?
Yeah, it can always be done. It will be very helpful.
So how do we do any of the panelists can answer, how do you intraoperative ultrasound, TVS, TAS?
Transvaginal can be done even, it depends on the size of the uterus basically. Sometimes transvaginally, a very high up fibroid is not visible. So both ways,
Both the
one should
approach.
try. One should try both ways.
This is because the bladder is not full, you put a Foley, so you can fill the pelvis with saline. That will give a contrast and let them do a transvaginal in other ones, and they will tell you. Now there are few things called laparoscopic tip has an ultrasound. Laparoscopic ultrasound probe has come, and there's something called hand assisted laparoscopic surgery, which I am not in favor of, because if I feel I can put my hand, but this lap ultrasound probe is a new innovation which can help us in locating the fibroids. Now, suppose you start doing the fibroids. Is my video visible? Is it running?
Yes,
yes.
Yeah. So the videos will keep running now one by one, but you all can keep answering. These are studded. The uterus is studded with fibroids. You don't know where to start from. We also have to make sure that you do all the subserious and you leave one small submucous. The purpose is defeated. So do a hysteroscopy if the MRI picture is not clear. Now coming to Dr. Dr. Tabassum. Which ones would you like to remove all of them and then do the suturing, or you would keep removing 2, 3 and then do the suturing? How will you progress?
If the bed is not bleeding, I would remove every fibroid and then I can later on suture each and every one.
Okay, and what measure do you take for lost fibroids? Because you have kept 7, 8 fibroids. What all measures will you take to prevent this?
First, I will put endo bag before starting myomectomy so that I start keeping the fibroids inside the endo bag. Otherwise, I can also park the fibroids in front of the uterus.
I think this
just
is
above the
very,
bladder.
sorry to interrupt, but it's very tedious to put the endo bag first, because it will occupy your space. So it's better you count it or keep it on the right side
Yeah,
of
we
the
can park it at a particular place, especially in front of the uterus. There is a good space there. So there we can park all the fibroids at one point.
Suppose it gets lost. For example, still you can't find at the end of it. Sister is marking on the board, and she says, "Madam, 5 nikal the 4 million." So what do you do next? Where do you search for the fibroids? Where do you start your search? Doctor, Dr. Sonali can answer. Sonali Agrawal.
Yeah, usually head lobe we have given. So these are usually pulled in the abdominal cavity, like right or left. So thorough examination is very, very important. You look for the sites where you have kept all the and search it first. First, if I've kept it on the right side, we look for the right side, all the spaces, and then we look. If we are not finding it, then we have to search accordingly. If not, then
anywhere, but the most subdiaphragmatic, because it is
diaphragmatic, right? Upper part.
Head up, head up position should be done. The patient can be made head up.
Head-up position, and if we put in a large amount of saline inside the cavity and give a thorough lavage, maybe with the saline, the fibroid drops into the pelvis from the upper part of the abdomen, and then it is very, very easily accessible for us.
These are various ways, but best is to stand between the legs of the patient, and like how they do gallbladder, turn your camera like from below, you go and stand on the other side, turn it towards the liver. Most of the time you will find it in that pouch, Morrison's pouch somewhere. Otherwise, putting saline, washing, giving head low, head up, checking between bowel loops, all that has to be done. Now coming to the steps of myomectomy, we go back to Dr. Anupma now. If Dr. Nidhi has joined and Dr. Divya Sharma have joined, then they can also answer. Dr. Anupma Gupta, so any fibroid, we start with these basic steps which I have written: enucleation, separation, incision, and all these steps. So what kind of incision would you tell me about? Incisions, transverse, vertical, what would you like to give? अच्छा चलिए इससे आगे बढ़ते हैं, 1 minute. Sorry, let's move ahead. There's another case where we'll cover this. Case 3 is a 40 years old unmarried girl. She's still not married, at a high position in her workplace. She has a 28-week size uterus. Her MRI shows a bulky uterus with multiple fibroids, whole uterus studded with fibroids scattered all over. The largest is 11.9 into 12.6 centimeters and causing deviation of endometrial strip, both ovaries normal. Her symptoms are moderate bleeding, but she's not much affected. She wants to remarry and wants to conserve her uterus. These are all real life cases. I have operated upon them. So she's 40, studded with fibroids, whole very big uterus. What are the entry techniques for large myomas? Port entry sites, Dr. Anupma, we'll start again with you.
So, in large myomas, we can either go for a Li Huang point, that is like just under the xiphisternum or midway between the xiphisternum and the umbilicus. So, we can opt for a higher primary port and accordingly plan the lateral ancillary ports. Right. The Jane point is in cases of previous surgeries, I would opt for Palmer's point or Jane points. Otherwise, I usually prefer that we put a 5 mm scope from a Palmer's or Jane's point. Jane's point can later on be used for an ancillary port as well. And then introduce the primary port in the Li Huang point.
Okay. And would you do a blind entry, or you would go with, of course, you said under anyone who would do a blind entry who's used to doing a blind entry? Many people by routine, they don't put a Veres. Anybody among the panelists does a blind entry?
Yeah, I go for
I do a blind
actually
entry.
use blind entry.
I also do a blind entry only.
So you are comfortable, whatever.
Entry
Yeah.
Right there. At Li Huang, if you see in this diagram, Li Huang is here and the aorta is right there. But still and your sharp trocar or your blunt trocar?
Blunt trocar, madam, for
Blunt trocar. Yeah, so I think this is the correct way. Even the youngsters who are watching, safety is most important. And there's no way that blind or Veres or this will prevent injury. What you're used to, what you have excelled in.
And specifically for Li Huang point and Jane point, whenever we are using our entry from the upper abdomen, we have to ensure that the Ryle's tube is in place so that the stomach is deflated. Otherwise, we are likely to injure the stomach.
Yeah, so stomach, spleen, splenomegaly, everything
Spleen
has
is to be spleen is to be palpated and
so this is a traditional conventional point port placement, and this is in cases of large masses where the basic thing is that you are looking able to look caudal, not down, because if your laparoscope has to look down, it will be interfering with your working. About 8 to 10 centimeters or one palm width above the highest point of surgery. Now, any large fibroids, you're counseling her. She is like 28, as I said, 26, 28 week size. Would you counsel her for open surgery? This patient?
No, see, whenever we take a patient for laparoscopic surgery, we as it is take consent for open surgery as well.
Right.
Lekin prima facie, I would not be opting for an open surgery in this particular case. Depends again on the expertise of the person who's doing, and if I expect the surgery to go on for more than 2 hours, then the whole purpose of laparoscopic surgery is defeated. That is
And
the way I
also
feel.
the setup where you are operating, what kind
Correct.
of instruments and
The
what kind
expertise,
of
the blood arrangements, the backups, the instruments, the type of instruments that you're having, and of course, what the patient wants as well.
So this patient, when we look at her MRI, you can see the whole uterus is almost coming to the Xiphi sternum. This is a large fibroid, few more. So we went in with, she was very keen to do it MIS. We of course counseled her for open surgery. We started with robotic surgery in this case. This was a huge abdomen. So wherever I put my foot, I'll still be sitting on the fibroid. I'll not be cranial to the fibroid. So we started, my idea was that maybe one large fibroid if I remove, then rest of it I can remove through a smaller, if not very large, slightly smaller incision. I will not have to give a vertical long incision. Otherwise there was no way. By Fenton steel I wouldn't have been able to remove it. So we did remove one or two fibroids. I'll just show you, this was the one fibroid. And as you see, there's no place for anything to move. To say if bleeding had started, what I would do. At this point, we abandoned the procedure. So at any stage of your career, there may be times that you may have to open up the patient. Hesitate. Here, this was the final view. After we sutured, when we looked inside, this was the uterus with so many stitches, as you see. And we could remove, by opening up, we could remove 17 fibroids. And the largest one, if you see with the scale, is 15 centimeters. This was the largest fibroid. So this was an interesting case. Patient did well. She did receive bloods and all. Now, what techniques would you use for Dr. Atishay Jain? There are a lot of approaches available for preventing bleeding in these cases. What are your choices out of these?
So ma'am, we prefer vasopressin, and in cases where there are multiple fibroids or big fibroid, we always go for the retroperitoneal dissection and uterine artery ligation at the origin with a temporary knot.
But with a very large fibroid, are you able to find space which is totally filling up the abdomen? Are you able to find space to go retroperitoneal?
It's difficult, but in certain cases we do find space. In certain cases we don't find space. So where we don't find space, we try to enucleate the fibroid with the help of only vasopressin, and we've even tried putting a Foley's once.
Foley's where?
At the level of the uterines.
So tying the uterus, like at the.
For tying the uterus, yeah.
We discussed about, Dr. Uddhav told us about the clamps, the bulldog clamps.
Yeah.
Panelists, anybody is using the bulldog clamps routinely?
No, madam.
No, ma'am.
I think it was a nice lecture. We should start trying and using them, because I have also not used. So this was a large fibroid, a degenerated fibroid. The video is not running very well. Suddenly one big spurter started bleeding during separation. So at that moment, whatever instruments are in your hand, you start to control. But if it is not controlling, remove the instruments and get the proper instruments. Like for example, irrigation, suction I brought, bipolar I brought through the proper channel, and then we could control the bleeding. The next thing is quick suturing is the only way in large myoma beds to get hemostasis. Bipolar you may use only for one or two spurters, but not as a whole. You should not try to coagulate the entire bed.
Now, one more technique to control the bleeding is which has been very conventional sort of technique, that if there is no much of the space available, we make a small window in the broad ligament, pass infant feeding tube through that, and through the same window we can tie around the internal os to control the as well as at the infundibulopelvic ligament, both on both the sides, right and left, and then just pass a piece of catheter over the two ends of the infant feeding tube and put a clamp so that the hemostasis can be achieved. This is a conventional method which we have been
also be used. Temporary sutures can also be used.
Yeah, as a last resort. So don't wait for the patient to become with absolutely hypovolemic. When you are doing one thing and it is not working, tell sister for the next step. Make patients ready.
And also we can talk to the anesthetist in such cases beforehand, so that they keep the blood pressure at a lower level. That way also they help a lot in many cases. Yeah.
So we have this drug vasopressin, which is a wonder drug. Anybody among the panelists can say they have faced a problem with vasopressin, and what was the problem?
Yeah, sudden
bradycardia.
Sudden severe hypotension.
You have seen in some cases. So these are known complications of vasopressin. Although it works so beautifully, I think most of us are using it and are very happy. We rarely have to go through this uterine artery ligation. This is a needle. We always say you should not inject into the blood vessel. So this little modification by Dr. Sanket Prasad has worked.
Yeah, that is a very good addition.
Visible,
Yeah, very helpful.
Where you just aspirate and you know. Otherwise, even if you probably how many women we have injected vasopressin in the blood vessels in the past. So there's no study which says how much you can inject, but 5 to 6 units seems to be sufficient. And you can dilute it as you require, 400 ml, 300 ml, 200 ml, and make it 5 to 6 units total amount of injection. Uterine artery, and Dr. Divya Singhal, if she's doing it, then you can please elaborate a little bit about uterine artery ligation.
No, I'm not doing uterine artery ligation, so I think I'll pass on the question to somebody who's actually doing it.
Shah, are you doing it sometimes? Dr. Harshal?
No, ma'am, I'm not doing regularly.
Okay, so the way,
You're doing uterine artery ligation regularly for a lot of cases.
Yeah.
So in that, first you start retroperitoneal dissection, and then you first you medialize the ureter, and then you trace the uterine artery at its origin, which is the first branch, which is going from lateral side to the medial side, which is crossing over the ureter. So in that, once it crosses the ureter, so you can just you can confirm it, and at the origin we in such
Shoelace.
cases, we put a silk suture with a temporary knot.
So this video you can see here the ureter, here this is the ureter, the bulge, here's the ureter. You just have to see it. You don't have to make it totally. I mean, you don't have to totally dissect it. The triangle between IP ligament, round ligament, and the psoas major muscle. This is the triangle which you open. If you see this video, we have opened this triangle. Stretch the uterus to the other side. Round ligament is here, and then we are going to the triangle area. Monica, let us know when we have 20 minutes left. I have 3-4 more cases so that we can finish all cases.
No, you can take your time, Dr. Jyoti. You can take.
I want to ask one thing. Why don't we use interventional radiologists for partially blocking our uterine artery at the level of origin and then try to do myomectomy? I had not done, but this just came into my mind, and I was thinking to ask
Matter of
somebody else.
cost. It is matter of cost. Involving them will add to additional cost.
And fertility issues can also happen later on.
But for the patient you are talking about, that she's unmarried, want to have more children, we should not land up into the hysterectomy.
She can have
also
fertility
give a
issues. She
suggestion?
can have reduced ovarian blood flows also because of that. So we
Can I
should
also
ideally
give a
avoid it.
suggestion? Actually, I'm sorry. I was disconnected for some time.
No,
Yes, it
in
does.
patients who are keen to have fertility in future, uterine artery embolization should not be the
Should
first.
not be done. Yes.
Can I add a point? Can I add a point here?
Yes.
Yeah. So basically, I'm sorry I was disconnected for some time. This uterine artery ligation I do routinely in such cases wherever I suspect, but we can take a shoelace knot. There's no need for us to put a clamp or permanently ligate with a silk. We can just put a shoelace knot even with #1 Vicryl, and the moment the bleeding stops and we are able to control the with the sutures, the bleeding point and all, we just pull on and the ligature is removed. You just need to skeletonize the uterine properly and take a shoelace knot, pull it out the moment the bleeding is secured. Another option, as she said, is uterine artery embolization with the vascular surgeons, but then that needs to be done pre-op. So before we start the procedure, they need to put in a catheter wherein maybe not a superselective, but a uterine artery embolization can be done. And they put in the catheter and they put in the
flap for that.
Embolization is not required. We can partially deflate the uterine catheter and then we can proceed for the surgery. And once
yeah.
they deflate,
So that is what temporarily we can do that. But ligation with a shoelace knot is a very good option. I've tried many times and it works well.
Yeah, this shoelace knot is very wonderful. It is very easy to be put and it is very easy to be removed.
Very easy to
So
be pulled out.
temporarily we can stop the blood supply till our procedure is done.
Exactly.
It works
Exactly.
wonderfully. It works wonderfully.
You just need to skeletonize the uterine properly at its origin.
I think take home messages. We talked of 2-3 controversial things. One is uterine artery embolization. See, they do with PVC particles, which can be bad for fertility. For temporary, they say they will do it with gel foam. Gel foam, I have seen patients' AMH dropping drastically after this. AMH had dropped and that lady could not conceive after she had to, that was a cervical ectopic and all those things.
Yes.
So I doubt whether doing uterine artery ligation, although this lady is 40, so as it is, she will donor eggs. Second, coming to shoelace knot, trick knot is another simpler version of shoelace knot. So any of them can be done, but sometimes there are situations where the fibroids are so big you don't find any place, and you have to quickly separate the fibroid and finish the suturing before it starts bleeding. Bipolar cautery has to be demotivated. The surgeon should not use it much, otherwise the healing will be poor. Now we switch from bleeding, we go to special situations such as broad ligament fibroids. A part of it was discussed. Dr. Harshal, I come to you. Dr. Harshal, what special, you have a patient with this kind of fibroid. So tell me how you prepare and what are the steps?
Ma'am, with broad ligament fibroid, first we have done a MRI for the mapping of the fibroid. Then you intraoperatively, we can use ICG mode as doctor in the first lecture is said. You can see where the uterine is going, and then we start our dissection. Dissection should be in the medial, not in the lateral. And then by being medial only, and we should avoid injury to any uterine in the ureter in these cases.
Dr. Divya Sharma, Singhal, you were left in between. Dr. Divya, would you like to add something? If you don't have an ICG facility available, you have a simple camera endovision system, what will you do? Broad ligament.
Madam, may I put my view put forward here?
Yeah, please go ahead.
Yeah, we may do a pre-operative uretary catheterization so that the ureters are properly palpable and ureters can be safeguarded while we are doing the myomectomy on the broad ligament fibroid, because the ureters are definitely displaced laterally and we are not sure where the ureters are lying. Or otherwise, there are some fluorescent catheters available through which whenever we catheterize them, we can see those ureters with the help of the fluorescence which is available, and the ureters are very easily visible, and then we can save the ureters and be away from the ureters and easily do our dissections.
Talked of catheterization of the ureters, ICG dye, and fluorescent catheters, but these are expensive things available in corporate hospitals only. Best
Better
thing is
to go up near the promontory, then laterally near the common ilia, and trace the ureter and separate the peritoneum so that the ureter is lateralized as much as possible.
Yeah. So because ureter is most easily visible at the promontory, where it is covered only by a thin layer of peritoneum, learn to dissect ureter in simple cases so that you can do it in. Like this patient had a hydroureter already known. So we started, and then as we move further, we dissected the ureter. It's like keeping the enemy right in front of your eyes. So then you see the ureter is here, you have to stay away from here. Even in suturing, you will know that you are not incorporating or stretching the ureter. Here's the ureter, dilated ureter you can see. Easy to identify. Dr. Atisha has probably been doing the ways how you identify a tubular structure.
Still in some cases, the vessels are so, like the anatomy is so much distorted. The vessels, the ureter, these all look similar. So one has to be very, very careful. Sometimes it is very confusing. So it is better to trace the ureter from high up.
Yes, and peristaltic short way. Now coming to Dr. Mudita Jain. Dr. Nidhi Nagar probably has not joined. So coming to Dr. Mudita Jain. Cervical fibroid patient comes with, she has been reported cervical fibroid somewhere. What will be your concerns? First thing, I think, what is the origin of fibroid is very important. How will you confirm that? Dr. Mudita?
Cervical fibroid will definitely require a good transvaginal ultrasound, and then doing a pervaginal examination is also a must to localize it that it's a cervical fibroid.
Sometimes it is reported and you find a whole pedunculated fibroid lying in the vagina.
Yes.
So it's very important to do a perspeculum, and of course ureters and bladder is at risk, which we have already discussed. So sometimes you have to suspend the ovaries because if it is falling when you're doing the cervical fibroid, and then you can do the surgery well. Coming to case 4, Mrs. SM, this was a recent case we did last month. 35 years old, P1L1. She had a small child, 1.5. She had a cesarean earlier. No, this is a different patient, sorry. This 35-year-old P1L1, heaviness in lower abdomen for last 6 months. She says she may plan pregnancy in future, not very sure right now. She's working with IT, a very well-read Google doctor, and she has been changing doctors. She's not satisfied with anyone, and you are the 4th doctor. On per abdomen, her uterus is 14 to 16 weeks size. Cervix appears normal. PV uterus is 16 weeks mobile. Fornices are free. Ultrasound shows bulky uterus, subserosal fibroids, intramural component 9 into 8 centimeter along posterior wall of the uterus. ET is normal, ovaries are normal. She's very conscious about the scars and she wants quick recovery. She wants to join back work. She wants to go for hiking. Now, what would you offer her? What will be your counseling in this patient and how will you go ahead? My next person is Dr. Sonali Agrawal. Dr. Sonali.
Incision, we'll counsel for the laparoscopic first. And
Yeah.
then whenever we are doing laparoscopy, we do counsel the patient because she's a very cosmetically conscious patient. So then we have to give an idea. Our port will be where and the main ports and all. And always counsel the patient of 1% chance of we can convert into a mini laparotomy. So this will be the counseling of my patient, and we can give an incision like intraumbilical so that the scar is not visible.
Any more inputs? Anyone else?
Yeah, I think here we are discussing about the placement of our incision on the fibroid and the uterus rather than the skin. Am I right? So if the fibroid is completely on the posterior surface and it is a big fibroid, so we would like to have a scar on the posterior wall of the uterus because it can cause adhesions and future fertility may be adversely affected. So here I would like to create a transverse incision on the anterior surface somewhere around the round ligaments and make a Boni's hood and then take out the fibroid from there and then cover the extra myometrium anteriorly and then stitch it so that the strength of the incision on the uterus is better after healing.
Okay. Sorry, my battery had gone low.
Because vertical incision is not preferable. The blood supply is minimum over there. So healing would be comparatively not that good as it is in the transverse incision because definitely in the midline, the blood supply is minimum. So it is likely to give way in next pregnancy or maybe during next labor. So I would prefer a transverse incision on the uterus.
I
think,
would
scar
suggest
on the-
for the posterior fibroid, the ideal incision is vertical. But of course, it depends on the comfort and the expertise of the surgeon, whichever way you are comfortable. But it should be done as according to the direction of the fibers of the uterus. So the ideally for posterior fibroids, a vertical incision needs to be given. But if suturing is difficult, we can make it oblique, we can make it transverse. Depends on the comfort and convenience of the surgeon, plus the port placements. And as far as cosmesis is concerned, I would suggest that we do it with the 5mm camera and the 5mm ports. But the patient needs to be told that for the morcellator, we have to increase the incision of one of the ports to 12 mm or 15 mm, depending upon the size of the morcellator that we have. So this much she has to accept. Other ports can be just 5 mm and that's good enough. And regarding the tunneling, if required, tunneling incisions can be made through the vertical also and through the oblique or the transverse incisions also. But vertical incision, if given for a posterior fibroid, the healing is much better, faster, and we can always put an interseed over the suture line so that the adhesion formation is less. And plus, what I do is I take kind of, you can say, I don't do the baseball suturing. I take kind of subcutaneous, like we do subcutaneous in the skin. Similarly, such sutures are taken, vertical matrices, so that the serosal layer is approximated and there are not too many sutures exposed or to the outside. And if you need for hemostasis, then instead of barbs, simple Weichel sutures can be taken over the serosal layer so that adhesions are minimal.
So I think that was very interesting. In between, I lost touch for a minute. I think this has been discussed very well. So one very important point is if you are an ipsilateral surgeon or you are a contralateral surgeon. If you're an ipsilateral surgeon, the transverse incision usually helps because you can take bites from anterior to posterior. And if you're a contralateral surgeon, vertical helps. But for myomectomy, you have to be prepared with any odd incision also, odd positions also, because fibroids could be lying anywhere. And especially posterior wall fibroids are most difficult to suture, especially those deep down, because their instrument they're almost parallel. They don't go, the needles you can't turn. That benefit you find in robotic surgery. So what are the fertility? My next person is Dr. Sonil Srivastava. Fertility preservation concerns. How will you, what precautions will we take to conserve her fertility? She may plan a baby later on. Dr. Sonil Srivastava. Are you able to hear me?
No, she's not there. She's not
Okay.
there.
Dr. Kanika is there? Dr. Kanika, fertility preservation, what points would you consider?
She is a 35-year-old, you said.
Yeah, 30. Then she may plan a baby. She's 35. She
Okay.
has one child. Yeah.
Okay. So as far as the surgical steps are concerned, for fertility preservation, we would make sure that the incision and the suturing does not involve the tubes or the cornwall end of the tubes. They stay away, and as far as possible. And if we are opening the endometrium just by chance, we should avoid. There are two schools of thought in it. One says that you should open the cavity and see if there are any submucous fibroids and then remove them. And I prefer not opening the endometrial cavity as far as possible. And we can always palpate for the fibroids or do a hysteroscopy to confirm the submucous are not left
But
behind.
normal course, we would stay away from the endometrium.
Stay away from the
As
endometrium.
much
Try and
myometrium
preserve as much as possible. Even if it's a bulging endometrium, you leave it intact. That also is good enough.
The flap.
And then it can be always superimposed with some sutures not taken in the endometrium, but towards the mucosa, and just reinforcing the strength of the endometrium. And if the endometrium is open, then we have to warn the patient that a quick pregnancy should not be done post-surgery. Then she needs some time to heal so that there is no issue with the scar dehiscence or other things.
Yeah.
Yeah, I have a personal opinion over here
Yeah.
that whenever the endometrial cavity is breached due to the dissection, of course, we are not supposed to do that, but suppose it is breached, while we are suturing, the endometrium is very difficult to suture because it's not a continuous membranous layer. The myometrium, which is just adjacent to the endometrium, has to be brought in front of each other, and that has to be approximated properly so that it gives real strength. And in the next pregnancy, the chances of dehiscence are very less.
Exactly,
So the
ma'am.
idea is,
And the submucosal layer needs to be approximated, and then
yeah, that's what I'm
muscle.
saying, that the myometrium very adjacent to the endometrium has to be taken care of. You
It
have
has to be
take care
taken
of
in
that
layers.
particular area so that the strength of the
It's like we need to do
all
some
the-
delicate embroidery over there,
Yes.
rather
Right,
than coarse stitching.
And now you can fill the endometrium with methylene blue. So if you start seeing that thinning bluish color, or nowadays indigo signing people are filling in, if they start seeing the fluorescence, they know they are coming very close to it. So they stop at the fibers that level.
Some people even like to put methylene blue inside the uterine cavity so that the
Yeah.
endometrium is nicely delineated.
These are old simple
avoid
methods
it
which
by
are very
taking
easy to
care of.
use. We can continue with that. Dr. Tabassum, do you think robotic surgery will have any benefit for these patients? Fertility preservation, where that is a concern.
Yes,
Like
robotic
for this
surgery. Yes,
video, how
robotic
beautiful.
surgery will definitely be better. But very experienced surgeon, I will also be. They will be doing it better. I mean, it would be equivalent. But yes, definitely in multiple fibroids, especially robotic surgery will have an upper hand sometimes.
Yeah. So ultimately, it is not the man behind the machine, but we see how you see the tips of the movement, instrument tips, how beautifully they are moving. They are going into narrow spaces also. And as many layers I want to take, because usually at the end of the surgery, you're so tired. Of course, all of the panelists must be very good surgeons, laparoscopic surgeons, but then you're really tired to finish that suturing. In robotic, it's just a child's play, what you're seeing here in this video. Now, I think we have already discussed this problem of entering the endometrial cavity, but the studies have shown that all those women where endometrial cavity was breached, there was an increased risk of placenta accreta syndrome. So that has to be taken care of in the next pregnancy. Now, risk of uterine rupture, how do you counsel them for the next pregnancy? Dr. Sandhya Gadre.
After a myomectomy, we have to ensure that while doing myomectomy, the hemostasis is properly done. And once again, as we already discussed, that if the endometrial cavity has been breached by our dissection, we have to ensure that the myometrium, which is very near to the endometrium, the submucosal part of the myometrium has to be approximated properly so as to give the good strength to the uterine musculature.
Yeah, so the studies have shown that risk of
And
uterine
patient has to be warned not to get pregnant very soon after the myomectomy. Let the wound heal properly, and then she can go ahead from a
3 to 6 months gap. Usually 6 months is outer
Yeah,
side.
that has to be kept in mind, and patient has to be counseled accordingly.
Yeah, I
And
think
of course, suturing, we have to ensure that proper hemostasis is there, and secondary infection after the surgery is not there. We have to cover her with good antibiotics.
these are the ways how you give a strong scar by avoiding this excessive cauterization and giving good hemostasis, good antibiotics.
And we have to suture the bed in multiple layers so as to ensure a good strength to the wound.
Yeah. Dr. Tabassum, now the next question. Nee, Tabassum, yeah, it's your turn. Such large defects where you may have a shallow defect, a very big shallow defect, or you may have a small deep defect. What would be the difference in suturing these defects? Like a plate, like a dish.
In different layers. Shallow defect, it would be a baseball suture kind. But if it is a deep defect, then I would suture it in 3 different layers.
Yeah, 2 or 3, whatever is required. And all the time we stay away from the endometrium, we avoid exposure to the peritoneal cavity. The idea is to achieve hemostasis as well as give tissue strength. And suture material, I think you all were discussing for that 1 minute where I got disconnected. I think barbed has been discussed. Once again, anybody can summarize, Dr. Anupma, barbed suture benefits over polyclectin. Dr. Anupma, I hope you're using barbed sutures now or you're using polyclectin Vicryl?
All of us are using barbed sutures mostly, but
Yeah.
then sometimes when the myoma bed is deep and I tend to take a box suture with normal Vicryl at the base, gives me a very good approximation, and then go ahead with barbed suture for subsequent layers.
Yeah, so whatever is your convenience, barbed is much faster surgery. It's not just a knotless suture. It gives pressure distribution is at equal places, and knot is said to be the biggest nidus of infection. Here it is knotless, we are preventing infection as well. But of course, cost has to be taken care of. Now, coming to baseball continuous interrupted, I think we have discussed. Coming to our last case, Mrs. N.A., 34, this was done last month. She was diagnosed with intramural fibroid during cesarean. 34-year-old lady during cesarean. She was told 2 years ago that she had a fibroid of 5.6 into 5 centimeters, but doctor did not remove it because it was not that feasible. It was on the posterior wall. She had heavy menses when she resumed menses. Ultrasound after that showed 7 into 6 centimeters fibroid. So this was at the time of delivery 2 years ago. It was 5.6 into 5. Now it was 7 into 6. Marginal increase. MRI done showed 11 into 9 centimeters uterus with a large degenerated fibroid at fundus around 7.5 or so centimeters, extending to the endometrial cavity and displacing the endometrium. Hemoglobin was 7 gram%. Per abdomen uterus was 12 weeks. In PS, because of previous to cesarean, cervix could not be seen clearly. And on PV, enlarged uterus, fullness and posterior fornix was failed. Now, would you counsel her? It has increased from 5.6 to 5 to about 7 into 6, but now it is a degenerated fibroid. Would anybody advise myomectomy or keep under watch? Dr. Divya, Dr. Atishay Jain.
Ma'am, we would, correct the hemoglobin and then advise laparoscopic myomectomy for her.
Okay. So this patient underwent myomectomy. We did it was a degenerated fibroid, so we did a hysteroscopy also where we found extension. But since we knew it is a huge fibroid extending from the serosa to this place from the muscle layer, so we went in laparoscopically. It was no point removing it partially from below. It looks like an absolutely normal looking fibroid after vasopressin. And we did myomas too. What can be the other causes of degenerated fibroids other than, like, what are the causes rather of degenerated, Dr. Divya Singhal? We kept it in a bag and we removed it nicely. Everything seemed to be perfect and we are very happy. Anybody?
Sarcoma can be there.
Yeah, what else? Which other fibroid can look degenerated? Normally degeneration happens when the fibroids grow
faster than the vascular supply. When they outgrow their blood supply, then then degeneration can happen. This patient, such a beautiful done surgery, and the histopath came out to be low-grade leiomyosarcoma. IHC confirmed it, and then we did a TLS just yesterday. I've done her TLS. She's in the hospital still. So, anyone would say any role of lymph node dissection in cases of leiomyosarcomas, or do we need to dissect pelvic lymph nodes? Anybody can answer. See, I did a lot of reading because these cases you don't see every day in your practice. First, let's discuss what is the difference between degenerated and leiomyosarcomas. We all know these are very aggressive myomas, sarcomas, whereas degeneration is where it has outgrown its blood supply. A typical leiomyoma will have mitotic figures less in number, 0 to 3 per 10 high power field, whereas here it will be 10 or more per 10 high power fields. And along with necrosis, there are 3-4 conditions out of which 2 are met, then you can call it a leiomyosarcoma. And we did an IHC also. Now, how do we diagnose it? The question goes to Dr. Harshal, Dr. Mudita, Sonali, anybody can answer. How do we diagnose leiomyosarcomas? How suspect before surgery?
Ma'am, if it is fast growing tumor, and when we put the color Doppler, there is a high vascularity, say zone 3 or 5. There are mixed echogenic. There are areas of necrosis also. So these are usually isoechoic or hypoechoic in on ultrasound. So, and these are the point, and it's a very high vascular supply in this.
Dr. Kanika, Dr. Sandhya, anybody wants to add? Dr.
We can also go for levels of LDH in this particular case.
Yeah. So
LDH can give us a guideline whether it is going towards leiomyosarcoma or it's just a degenerative fibroid.
LDH can be raised in many cases. This study says that in this particular study, it is said that a combination of CA125, LDH, and HG4 together can be promising. They're not very long, very good database because this fibroid is leiomyosarcoma is quite a rare entity. MRI also can give us some idea about some clue that it could be leiomyosarcoma. So all these cases we are very we can't do much because the moment you give an incision, you're exposing the peritoneal cavity to the sarcoma. But you can at least put it in a bag, prevent flying of pieces, and avoid dissemination. And
I suppose if it has been converted into a malignancy, doing a CT can give us an idea about the lymph node size and whether it is spreading, or accordingly we can go in a retrospective manner that yes, it is probably a malignancy.
Yeah, so we did a PET scan for this patient. I got an oncological opinion also done for her. And as I read the literature, it is mainly hematogenous spread with low-grade sarcoma. So pelvic lymph node involvement is only in 5% of cases. If you weigh the benefit and drawbacks, the disadvantages of doing a lymphadenectomy, it is not advisable as per books, but I did do her lymphadenectomy. It is said that if you find notably large lymph nodes, only remove those. Or in today's time, one can do sentinel lymph node also. But I did complete pelvic lymphadenectomy in this case. Now, what are the specimen removal, like in-bag? Who all are doing in-bag morcellation? Are you all doing all cases or specific cases? Which cases? I think anybody can answer because now we are nearing the end.
It's better to go for in-bag morcellation for every case so that we are well adversant with the technique. So as and when it is required, we can go ahead. Otherwise, if it is an undiagnosed leiomyosarcoma and we are not habituated to it, we are likely to spread it. So it's better to make a habit and get trained with the in-bag morcellation so that we are safe with each and every case.
Dr. Sonil Srivastava, what are the drawbacks of, what are the risks involved with morcellation? Dr. Sonil Srivastava. Dr. Sonil, are you there? Or Dr. Sonali is there?
Yes.
Yeah.
So, ma'am, this is the very morcellation is very important. Practice is very important. Morcellation in bag is very important. Otherwise, these myomas are very parasitic. If you don't use endobag, then the bits of myoma can be spread, and there can be disseminated leiomyomatosis later on, so that we can prevent with the this technique. And risk, there can be sometimes invertent bowel in this morcellation if you are not using the in-bag morcellation, and definitely you need a expertise in this to do this.
So Dr. Atisha Jain, what do you do in your practice? Like FDA has given some recommendations that it was withdrawn in 2014. We all know the story. So are you completely following the ban and not doing any open morcellation?
Ma'am, we individualize the cases, and whenever we have a doubt, then only we put a bag, but routinely we don't.
A very small fibroid, solitary single fibroid, we may do a normal morcellation or sometimes a colpotomy.
So FDA's recommendation was still recommends limiting the use of power morcellation to certain only appropriately selected women, and then morcellation is performed. It should be done in a bag. Inform patient communication. Everybody stresses on communication, that you should communicate with the patient. Ban is not a complete ban. Use of power morcellation is not banned, but it is now severely restricted to appropriate cases and requires contained morcellation. Now, what are the, suppose you don't have the facility or your morcellator doesn't work or anything, what all choices will you have? We come to Dr. Divya Singhal, Dr. Harshal, Dr. Mudita, all three of you can give in your inputs one by one. What are the alternatives to morcellation? You have a large, like a 7-8 centimeters fibroid.
A small mini lap can be done, as in earlier lectures I have shown. We can do a mini lap of 4 centimeter, and we can just remove the fiber. Even you can do a suturing from there also. As Ragnar Sushmita has just told, colpotomy can be done if very small fibroids are there. It is little difficult.
Yeah, so this video is not playing very nicely. So here this is Alexa's device. Even if you don't have a device, you can use retractors, but device, I usually prefer putting the fibroid in a bag, like a Euro bag also. You cut the top and bring the fibroids in a Euro bag, so that whatever pieces are falling, they fall into that, and keep on lifting it up and give half cuts. I don't amputate completely. If you give half cuts, it becomes like a long specimen, like a long piece, and then you can remove it completely. And there are other methods like this laparoscopic blade. We have been trying to do things. On the right side, what you're seeing is a monopolar hook. After the fibroid is separated, you can sometimes use a monopolar hook, but make sure that you're not hanging it in the air. It should be touching, it should be resting on the uterus. This, the left side image, what you are seeing is a laparoscopic blade, which I'm using, which is like a normal scalpel. One second, go back and play this. I think the videos are tired. They're also not playing. But in between, suddenly we found that the harmonic blade tip had disappeared. So we were not sure if it has got stuck in the tissue or it has gone flying somewhere. And that was something, I mean, worst could happen, such a sharp blade. So we tried to cut that area with the harmonic. Finally, we found it somewhere on the omentum and gradually picked it up and took it out. This video is playing a little slow. Let's move. Yeah. So if you see I'm cutting with this, 2 people can hold it and then you can cut this. Colpotomy is again, should not be forgotten. When nothing works, then colpotomy does work. Oh God, what happened to my computer? Oh, something happened to my desktop. One second. Yeah.
You can leave and join again if you want.
Okay.
The presentation has stopped, I think.
Check my audio devices, cancel. I think I have just few little left. I'll just share it once again. Maybe I can start sharing, then it will.
You have got everybody glued to the panel, Jyoti Didi.
Such interesting. I'm glad on the.
Everybody is there, you know.
Is my presentation visible?
Not yet.
I think I'll leave and.
Yeah. No, it started. It started.
Okay, so I'll go to the last few slides.
You can make it full screen.
Yeah, I'll just go to the consent slides. We were here. So I'll skip that slide, which gave us the trouble.
Yeah, it is 51, 52.
Where is full screen? Okay, so colpotomy is something we should not forget. Here it is. Yeah. Is it full slide? Or it doesn't matter whether it is full screen or not. Now we are.
Yeah.
Colpotomy is something which we all need to remember. Now, parasitic fibroids. How do you deal with parasitic fibroids post-morcellation? And what measures do you take to prevent that? Dr. Sonali, Dr. Sonal, anybody can answer. Dr. Mudita has been quiet for quite some time. Dr. Mudita, are you there? This was a parasitic fibroid. She had a history of previously done myomectomy. And somehow I feel this patient, I had done this mini lap, and then I just put in my hand, and suddenly I felt something solid. It was probably sixth sense which prevailed, and I could locate this fibroid. Otherwise, she would have said that I have left this fibroid in my case. So Dr. Mudita is probably not there. Dr. Santoshi and Sonal, we have discussed about in-bag morcellation, so I think that has already been discussed. Even if you lose a fibroid, one should be careful to search for it and take it out. What steps do you take for adhesion formation post-operatively, Dr. Harshil?
Yes,
Dr. Harshil? Adhesion prevention.
Surgical and intersealed. And if nothing is available, then saline.
If what is available?
If surgical or interseed,
Yeah.
if these things are not available, at least we can put some saline, leave some saline before we come out.
The different schools of thought. There was a time when everybody left saline, but then it is said in 24 hours it is absorbed by the peritoneum. When you put interseed, be very sure that there's absolute hemostasis, because in presence of bleeding, if you keep it, you are inviting more adhesion. So that should be taken care of. And it adds to the cost. Some last two things, stump. Anybody has come across this stump, smooth muscle tumor of uncertain malignant potential in their practice?
Yes,
These
I
are very-
had one patient. She was 20 years old and she had multiple fibroids. And we did her myomectomy, and the report came out as stump.
Okay, so these are very
Very
pregnant.
much here, my voice was not coming, and we came across struma overi also for such a patient. It was very rare case, and it was been published also.
Okay, struma overi, would please tell exactly what happened in the case? Dr. Mudita.
Sorry, ma'am, I'm there.
What was your case?
Ma'am, we were it was reported as fibroid lesion only, so we had planned the patient for myomectomy only. But later on, when we started doing the surgery, we came out that it's not a fibroid, and it came out to be a mass without a capsule, and it was reported in histopathology as struma overi.
Okay, interesting. So we can have surprises. We can have diffuse peritoneal leiomyomatosis. It is not like parasitic fibroids have gone there. Sometimes the peritoneal mesothelium undergoes metaplasia and can give rise to this condition. And it looks like peritoneal cancer sometimes. So how do you manage laparoscopic myomectomy? I think this is a very simple question. I don't think we all know when we come across on the table, it was diagnosed as fibroid. But whenever there's endometriomas with a fibroid, I think of adenomyoma first. Whenever there are endometriomas and a fibroid, it is most of the time adenomyosis or adenomyoma. So we all know counseling has to be done, because adenomyosis you cannot completely remove. Some tissue will keep on showing that.
Yes.
So before we end, almost the last slide, what innovations, I think one by one everybody can answer, I think all my 12 panelists. What innovations or emerging techniques do you think will change the difficulties we encounter in the next decade with the AI coming in and so much happening? Any thoughts which we can take forward? Dr. Anupma, Dr. Atishay, one by one you can answer. Dr. Anupma? I personally feel, since I've started doing robotic surgery, I feel there's so much difference in the level of not only the meticulously how I can do the surgery, the precision, the overall quality of life of the surgeon also improves. Large fibers which would take so long now take much less when you do it robotically. You're not less tired. Your eyes don't strain so much. Your shoulders don't take doing suturing all the time. So that is one big innovation. Of course, the cost is there. This ICG dye has made the ureters very safe. And any other comments from anybody? Any of the panelists?
I think with AI,
Single port myomectomy and myomectomy with coring technique. That is also, and a single incision myomectomy. These are recent advances.
Even now, where we have V nodes, where vaginally there's no cut on the body, vaginal natural orifice surgeries. Even robot is coming up with a vaginal V nodes, like vaginal route will be used by the robot, so no cut on the body, or single incision robotic surgery is also coming.
Robot with AI techniques will be very good innovations, madam.
Yeah. Dr. Sushmita, the last take-home messages which you would like to summarize before I say thank you.
Fibroid mapping, counseling the patient thoroughly, and always be ureter minded. Like you have to identify the ureter in cases where there are multiple fibroids and the anatomy is distorted, and taking care of proper hemostasis, not leaving gaps in between the sutures. And this is how we can give a good outcome in case of myomectomy.
Thank you very much, Dr. Sushmita. I think if we keep on sitting, there'll be hundreds of things to discuss.
Dr.
Dr.
Uddhav,
Monica.
any comments from Dr. Uddhav
Yeah, Dr. Uddhav, you're here.
Dr. Jyoti Mishra's panel? I know you must be knowing each other, but would you comment on the panel? And
I remember, Dr. Uddhav, when you and one more doctor was there, you both started doing freelancing. One more friend of yours was there, Piyush.
Yeah, thank you very much.
Yeah.
I think you've got an amazing memory. So usually I keep myself very low profile because I think so I think the panel was excellent, and I think these are practical points, and especially for the newcomers who have actually now very early exposure to multiplicity of techniques. That is the seat of confusion because they see so many good skilled surgeons doing multiple things. What is important is taking home the right message is very important, having good practice, having a good mentor. So I think all those points are covered very nicely. And I think Dr. Jyoti Mishra and all the panelists have covered absolutely all the technical problems and challenges which we are likely to come across in these cases. And finally, patient safety is of the primary concern, adhering to the principles of management, and the single most principle is primum non nocere. So I think the underlying fact is that we actually get caught in the surgical glory. So my word of caution, we also ourselves underwent that particular phenomenon in the early career. So I realized that actually doing surgery is not about heroism. Actually doing when not to do surgery, when not to do a particular thing is the more wise thing than sometimes doing the surgery. So because one complication can actually override many successful surgeries. So I think that is what I would actually summarize. And thank you very much, Dr. Monica and MPIAG chapter for this wonderful session. And thank you all.
Dr. Monica, I would say that being her senior today, I said, what, Monica, you've kept it on pre-Holi and everybody's in a festival mood. You shouldn't have kept it. She says, Didi, everybody will be glued, and I'm mesmerized by all my very actively participating panelists and the expert, and the entire team has really worked hard to make it so successful.
No, I
Thank
will.
you so much, Monica ma'am, for the opportunity,
Amazing.
and Jyoti ma'am, you were excellent as usual. Uddhav
Amazing
sir,
faculty.
really eye-opening. Your lecture was really fantastic.
So
we'll start doing
this idea actually came in February, and then we were working on the dates, but I was aware that Dr. Jyoti is very, very busy. Dr. Uddhav said yes, but we were trying to work it out. It got postponed twice, but ultimately we could do it one day before Holi, and now we can do the Holika Dahan and everything, all the festivities enjoy, because all of you have done a fantastic job. Jyoti Didi, nobody could have done justice to the panel as much as you did. And it was a very well-placed panel after that fabulous talk by Dr. Uddhav. So I'm going to trouble you again when we come out with some good endoscopy topic once again. And all the panelists were great. Dr. Sushmita, your inputs were totally awesome. And thank you, Intaz. Thank you, Vishal. Thank you, Purva, Nandini, Gunjan for that support. And wish you a very, very happy Holi.
I'm so happy I could see such excellent videos.
Yes.
Oh my God. So such excellent videos, and the clamp. That is also, and that is such an excellent innovation with all the sizes. It is something that is a great take-home message for all of us.
So, Dr. Uddhav, is it patented? Like you have it patented, or is it available?
No, I am a very low profile, as I mentioned. I don't like to patent anything. I don't like to put names to anything. So I just use basics. I don't like to name any points. I think everything is patient's point. Everything is patient's anatomy, and anything which fits there for that artery. Because I think we get caught in the industry. Harmonic will say 7 mm vessel can be taken. LigaSure will say. So I think these comparisons are irrelevant, because when we go to the surgery, on that day, everything what happens to that patient is very unique. But if we adhere to the basic principles, simple suturing, I still face a lot of discussions in my OR when people tell me operating, sorry, I'm taking a little bit of time, that what suture and why not V-lock, why not MAP suture. Then sometimes when we conveniently talk about cost and multiple myomas, I see people using many barbed sutures, and that cost we forget. And it is about, and then this common line is actually used very often in the conferences, which I personally don't agree with, that it is about your comfort and how you are comfortable with. It's not about our comfort. It's about exactly the principle of surgery. It's about exactly the principle of applied anatomy and surgical anatomy. There's nothing beyond that. And you need to get there. If you can't get there, you take a help of a person who can assist you to do that, or can do it for you. But in the end, the principle of minimal invasive surgery, the benefits of minimal invasive surgery should not be lost, and it should be applied only where it is appropriate, carefully selected. That's all I want to actually summarize. Thank you very much.
Very well said. Very well said.
Yes. Thank you
So,
so much.
Thank you. Thank you, Monica ma'am, and Jyoti madam. It was excellent. Thanks.
wish you all a very good night. Our next webinar is in the first week of April. Please look out for a great topic again. Thank you.
Okay, all the best.
Thank
Thank you.
You all of you.
Happy Holi.
Wonderful
Thank you, Dr.
talk.
Monica, for all this effort. Thank you.
Thank you. Thank you so much. Pleasure is all mine. Thank you.
Support team, please end the meeting.
Sure, sir. Good night. Happy Holi.
Good night.